कुलकर्णी सर म्यूट करता का?
हो हो हो.
पटवर्धन सरांचं का नाही होते बघायला पाहिजे.
सर पटवर्धन सर आहे तिथे, फक्त त्यांना अनम्यूट करावं लागेल.
सर यू आर देअर, पटवर्धन सर? पटवर्धन सर? सर ऐकू येत नाही पटवर्धन सर.
हा, ऐकू येत आहे?
हा, यू आर देअर. सो आय थिंक we'll start now. So very warm good morning to all the pediatricians and our friends attending this webinar today. As we are all aware, we are in the webinar era now because of COVID, and we don't know when we'll be live physically. So for this month, we have planned a webinar on the allied specialties, that is the pediatric orthopedics and the pediatric surgical branches. And we have a very eminent faculty to take us through the important topics in these areas. And I will hand over the mic to Dr. Manisha now to start the proceedings and after introduction of the faculties. Dr. Manisha, please.
Good morning, everyone. A very warm welcome to all the delegates and our panelists and faculty. A warm welcome to this webinar on orthopedic and pediatric surgery, pediatric orthopedic and pediatric surgery. So we'll start today's session. We have three eminent pediatric orthopedic surgeons from Pune. First, I will introduce Dr. Sandeep Patwardhan, who is a very well-known figure in pediatrics.
Just give me a second, ma'am. I'll just share the screen.
Yeah.
Can you see?
Okay. Yes.
Yeah,
yes.
You can continue.
Okay. So, Dr. Sandeep Patwardhan, warm welcome to you. A very well-known figure in pediatric orthopedics in Pune. Is a pediatric orthopedic surgeon specialist at Sancheti Institute of Orthopedics and Rehabilitation, and also a visiting pediatric orthopedic consultant at Bharati Vidyapit Medical College and Hospital, Pune. Next is Dr. Ashish Ranade, who is a pediatric orthopedic surgeon at Dinanath Mangeshkar Hospital, Surya Mother and Care Hospital, Pune, a visiting pediatric orthopedic faculty at Bharati Vidyapit, Pune, who has presented numerous international national papers, has more than 25 publications, and serves as a reviewer for several journals and is the editorial board member for 3 journals in pediatric orthopedics. And our third faculty today morning is Dr. Samir Desai, who is a pediatric orthopedic surgeon at KEM Hospital, Pune, and also at Jahangir Hospital, Ruby Hospital, Unique Children Hospital, Inamdar Hospital at Pune. He has a special interest in clubfoot, pediatric trauma, and cerebral palsy. And he is a social initiative in Clubfoot Medical Foundation and has developed a website for Divyang marriages. So very warm welcome to all our faculties, and I request Dr. Sandeep Patwardhan to start his lecture today.
Thank you, Manisha. Can you hear me? Am I audible?
Yes, you are audible.
All right. So at the outset, let me thank Dr. Sanjay Nathu, Dr. Kulkarni, and Manisha for inviting me to this webinar and sharing some information about deformities in children. So I guess my screen is visible to you.
Yes, it is visible.
Okay. All right. So when you talk of deformities, the most obvious thing is congenital deformities, but I will not be talking too much about that initially. I will talk to you about crooked limbs. The commonest problems that as a pediatrician you will see in your OPD are bow leg, knock knees, in-toe gait, out-toe gait, flat foot, and something that is now being identified as MMS, that is miserable malalignment syndrome. And what are the answers that you seek? You want to know what is normal. You want to know how to evaluate it. You want to know whether it needs treatment. Do braces really work? When do we offer surgery? So we have to start with understanding the natural development and alignment of the limb in a growing child. All of you know that initially when the child is born, we have a varus alignment, as you can see here, of about 20 degrees. And by about 1.5 to 2 years of age, that will come down and it will become near normal or neutral. I would say not normal, neutral by about 18 months to 2 years of age, somewhere here. And then from 2 years to 5 years, we are into a valgus phase, which can go right up to 10 degrees to 15 degrees of valgus. And then it starts coming back to normal by about 5 years or 6 years and stabilizes between 7 and 13 years of age. So what you have to realize is that this is the normal spectrum. 95% of the children will lie between this spectrum, and this is the normal development of the tibiofibular angle. This is a very important paper because it talks of the normal development in healthy Indian children, a study from Sion Hospital, Mumbai. And what they showed was that it is not important to take X-rays every time. Clinical methods of measuring the knee angles are acceptable and reproducible. And the advantage being it is cheap and doesn't need any radiation. Okay, so what you need to know is fixed bony points, which is the intercondylar distance and the intermalleolar distance, which we will highlight soon. Palpating those landmarks and measuring it in your OPD with a simple measure tape will tell you whether the child has a physiological bow leg or a knock knee or it's pathological, and whether further investigation know what is normal, then we can work on what is abnormal. So this is the normal alignment that you are able to see here. You mark the patella, you can draw draw the center of the ankle. So just simple clinical measurement. If you have a goniometer, you can use the goniometer, but that is also not required. What you need is just a tape. So measure the intermalleolar distance, and that will tell you what is correct and what is not correct. What we have seen is that in Indian children, by 6 to 7 years, the valgus, which is physiological of about 5 degrees, is stabilized. So anything more than 5 to 7 degrees after about 7 to 8 years definitely warrants observation. I won't say prevention, I'll say observation. It is out of the normalcy. And what is happening in our country is exactly what happened in the Western world. Couch potatoes and obesity. So childhood obesity is really changing the weight bearing and more and more deformities. So you know that obesity, medical conditions, what it causes, but I'll just highlight what it causes in orthopedics. We see a lot of children with slipped capital femoral epiphysis nowadays. We see adolescent age group tibia vara, which is Blount's. We see a lot of genu valgum, which is associated with obesity, especially in girls. We see miserable malalignment syndrome, and we are seeing a lot of stress fractures because these children also are in the sporting age group. So let's talk of bow legs. There are only 4 causes of bow legs that we see. One is rickets, second is Blount's, third is dysplasia, and fourth is physiological torsion. So we'll go through all of them. So look at these X-rays. The first X-ray on the left side is actually a physiological bow leg. The second X-ray in between is showing you epiphyseal changes here, which is suggestive of rickets. And the third X-ray is showing you unilateral bow leg with spiking or beaking of the proximal tibia. Now this could be Blount's disease. So what you should understand when you take X-rays, they should be in correct rotation, because a mal-rotated X-ray will give rise to an appearance of a spike. The ricket is pretty obvious, and you need some blood test to confirm that, where you have actual epiphyseal irregularity. And remember, blount is usually unilateral, whereas both the other conditions are bilateral. You that more about Blount's disease. If you are suspecting rickets, obviously, then you will get the alkaline phosphatase. And if it is raised, treat it with vitamin D supplements and calcium supplements. And in 6 weeks, all the radiological changes should reverse. If they do not reverse after 6 weeks, then you are justified in getting additional tests done to rule out renal rickets, such as urine pH and an arterial blood gas. So the first step is nutritional rickets. So you treat rickets, the changes go away, alkaline phosphatase come back to normal, continue observing them in the normal growth pattern. By about 6 to 7 years, the deformity will disappear. If it does not, we can help you. But 99 out of 100, they will resolve on their own. And what are the changes of rickets that have to go away? That cupping which you see has to become completely straightened out like that. So you see complete resolution of the cupping in the right X-ray. And that is the correction that you will see in some time of the deformity. Torsion is the second problem. So when you have a tibial torsion or a femoral torsion, that gives rise to a spurious appearance of bow leg. Okay, and you should know how to evaluate it. So what you need to do is, in torsion, these are the same X-rays of the same child. Okay, in one you have it in neutral rotation, one is not in the neutral rotation. So you can see double cortex on this side, which highlights torsion in the distal tibia. If it is not taken in the correct angle, misreporting can happen. Don't believe the radiologist reports. Look at the child, look at the torsional profile, and this is how you should do it. Put the child on the tummy and look from top. Normally, the foot should be pointing about 15 degrees outwards. In this child, you can see the left is pointing significantly inwards. Even the right is pointing inwards. So this is called thigh foot angle. And the normal, as I said, is about 15 degree outwards. If you see it's looking inwards, then you're looking at internal tibial torsion, which exaggerates with a slight bow leg and makes you feel that the child has a grotesque deformity, whereas torsion is the reason for all of that. So physiological bowing associated with torsion over a period of time is going to spontaneously improve. In about 2 years, you should see it corrected. If you find that the intermalleolar or intercondylar distance is more than 10 centimeters at 4 years, then it is pathological. Okay, we will come to this again. Now, this is definitely abnormal. A significant torsion with a significant bowing, which requires treatment. Now, this is also called an XO deformity, in the sense when you make the thighs parallel, the legs cross like an X. And when they are kept apart, it looks like the legs are in an O position. Earlier days, we used to do small osteotomies and fix it and give plasters. We no longer do that today. Today, we are using what is called as guided growth, using 8 plates. So we have a specialized tool, which is very simple, minimally invasive, and we put in small clips on the growing end, and we cause or create a teether so that the opposite half keeps on growing and we can get deformity corrected out. In Blount's, how do you know whether it is physiological or Blount's? There is an angle described, which is called metadiaphyseal angle. Okay, so this can be femoral or tibial, but this is proximal tibia is we usually measure metaphyseal angle. So MD angle between 11 to 13 can be pre-Blount. More than 13 is definitely Blount's disease. See, in physiological bowing, you do the tibial metaphyseal diaphyseal angle. If it improves by 3 degrees per group, there will be no change in this angle. It continues to be bad. So if the TMDA improves 3 degrees, Blount bilateral, eventually corrected with age only, because this was not exceeding the required parameters. And this is an example of a Blount disease. And very early Blounts, you can get an MRI to see the underdeveloped cartilage, as you can see here. This
So your connection is breaking. The connection is breaking. So can you
Sorry?
just stop your video?
ऑडियो नेट अवेलेबल नहीं होते.
Okay,
You
can you
just
hear
stop
me
the
now?
video. Yeah, better. Yes, sir.
हाँ.
Okay, what
मध्ये
I,
मध्ये ना आवाज ब्रेक होतोय कारण संदीप.
okay, I'll just stop. Can you just switch off my video? At your end, if you just switch off my video, probably it will be, okay. So,
Okay, you
are we okay
continue.
now?
If there is any problem, we will tell you.
So this is a classical Blount's disease, and in this disease we have
संदीप अजूनही डिस्टर्बन्स आहे. ऑडिओला डिस्टर्बन्स आहे.
So what do you want me to do?
बँडविड्थचा प्रॉब्लेम आहे.
Okay. Actually, I'm connected to a full signal is there. My connection is also quite
आता
okay.
व्यवस्थित आहे, sir. You can
आता
continue.
येतंय.
It's good?
Yeah, continue.
Okay. Just give me a moment. Let me get back to the screen. Can you see the screen? Hello, can you see the screen?
No, sir, not yet.
नाही दिसत आहे.
So I'll have to share again now. I think. Can you see?
हा,
Yes,
आता
sir,
चालू झालंय शेअरिंग.
Yeah,
now we can see.
All right, so I'll go to the screen share. Yeah. Okay, you can see that, right?
Yes,
Yes,
we
sir.
can.
Okay.
You can go.
Yeah.
Yes.
So this is growth modulation, and this is how you correct a deformity in very early or pre-Blount. If you pick it up very early, growth modulation can help. Whereas if it is late Blounts where there is a fascial depression, you will need an osteotomy. So this is an example where we had to do a osteotomy to correct the rotation as well as do a growth modulation. So this is what I call a staple plate. So sometimes 8 plate may not work and we may need to do this staple plate with a osteotomy. So this is correction of that child post surgery, and after the alignment is corrected, you will see that the medial condyle starts ossifying. This is a longer follow-up, and this is a 5-year follow-up when the plates have been removed and the leg now is well aligned. Sometimes patients come really late. This is adolescent Blount, very bad looking tibia, you can see that. And then they have to undergo really major corrective osteotomies to get the leg straightened out, what we call as a double oblique osteotomy with hemiplateau elevation. So that is the correction for that child from pre-op to post-op. But you can avoid all this surgery provided you pick it up pretty early. The third thing that I said for bolus, dysplasia. So when you suspect rickets but child is not responding, or your vitamin D levels have come normal, or your alkaline phosphatase is normal, then the irregularity in the physis could be genetic, which means dysplasia, and you should take X-ray of the hip and spine. So that will tell you that, okay, I'm looking at a multi-epiphyseal dysplasia or a genetic condition like achondroplasia, where we can again help with some growth modulation. So that is how we treat when deformity is part of dysplasia. But dysplasias will need prolonged treatment, and sometimes the physis does not respond as well as it does in rickets. So let's move on from bow legs to knock knees. And again, knock knees are 3 common types you will see in your practice. One is normal physiological, which I already told you, till 6 to 7 years. Second, because of rickets. And third, idiopathic. In our country, we see obesity as the single most important reason why legs go into a valgoid. If you are suspecting pathology, they will come with pain, stiffness, asymmetry, short stature, limb-length discrepancy, or laxity. And then you are justified in getting a skeletal survey, the metabolic profile, and some hormonal workup. What are the common causes of genu valgum? Renal osteodystrophy. So all your patients who have nephrotic syndrome or CKD cases who are on dialysis or need transplant, we see a lot of them coming with deformities of valgus. You can have metaphyseal dysplasia. You can have multiple exostosis. Genuvalgum is also very common in Down syndrome, in storage disorder, and rare condition called Ellis-Van Creveld syndrome. If it is unilateral, it can be because of trauma, infection, or previous surgery, and sometimes after a fracture. That's called Cosen's phenomenon. I'll just show you that. So how do you monitor? As I said, clinical monitoring. Measure the intermalleolar distance. If it exceeds 10 centimeters, it's pathological and it's not likely to correct with time. Bracing does not have much role. Brace inserts and bars have not shown to be of any value, and you need to treat the metabolic cause, if any. And again, we have two tools for correction: growth modulation and osteotomy. So an example of a post-rachitic genuvalgum, obviously you can see deformity is not acceptable, and you put the growth modulation clips and the leg straightens out over a period of time. In 12 months, the leg is straightened out. In Down syndrome, again, genuvalgum, and then you put the clips and it straightens out. So we can do a lot of wonders with simple small surgery. Unilateral proximal tibial valgus because of multiple hereditary exostosis, again, growth modulation, and that has straightened out. Renal rickets, you can have a multi-apical deformity here around the knee in the growth plate and in the diaphysis in procurvatum, you can see there. So we may need to do an additional osteotomy in the diaphysis and get that deformity corrected. So that is an example. Dysplasia, modulation and tibial derotation osteotomy. When can we not do the growth modulation? When the child is nearing maturity, starts menstruating in girls, X-ray shows that the olecranon epiphysis has fused. Then we don't have a choice of growth modulation. We must do an osteotomy. And that involves cutting the bone and putting a plate and allowing to heal in the correct position. So that is an example of
Again, there is
just give it time.
Audio disturbance, huh?
Yeah, just give it time. I think it's the bandwidth problem. Can you hear me now?
Yeah. Now we can.
Yeah. So long sentences, I think it breaks in between. All right. So this is now showing you that the deformity is corrected after an osteotomy. But we can avoid this if there is early referral for deformity, and you shouldn't wait till it becomes this bad, where we have to do really major surgery. Okay, again, a Downs with really bad knees, which have been corrected. This is Ellis-Van Creveld syndrome, polydactyly, bad teeth, and ghastly deformity. Neglected for so long, this could have been managed very well if she had come early with growth modulation. But then I had to do multi-level osteotomies and get that corrected. And in spite of which, the joint is never going to be perfect, though the deformity is gone. Okay, this is a 4-year follow-up, but she's likely to end up with arthritis. The last part is in-toe and out-toe gait. So torsional problems and miserable malalignment. So this is commonly seen with laxity syndromes. You check for the laxity, the Baton's criteria, extension of the elbow, flexible flat foot, and you see W-sitters walking with gross in-toe gait. So this is the simple test which shows you that excessive internal rotation and less of external rotation. Sometimes they have a foot deformity of metatarsus adductus, which makes you wonder whether it is in-toe gaits. So look at each component: the foot, the thigh, and the knee. Out-toe gait, again, in femoral retroversion. Reverse of anteversion is retroversion. You will get out-toe if you have slip capital femoral epiphysis, which you should rule out, and a flat foot, which we will come to. So if you have an obese child who has a mild limp with an out-toe gait and a small injury, please remember that he may have slip capital femoral epiphysis, because that is the only condition which needs intervention. All others have to be just observed and nothing needs to be done. So a bad out-toe, which is unilateral, commonly sometimes bilateral, will need surgery to correct by an osteotomy through the capital femoral epiphysis. What about flat foot? Another common condition in your OPD is flat foot. The commonest one is going to be benign. Symptomatic ones are the ones which need treatment, which we will come to: coalitions, neurological or congenital. So what are the types of flat foot? The common one is the mobile flat foot, which is physiological with hypermobility syndrome in obese children and rarely because of paralysis of tip post. The second is the rigid flat foot. So rigid flat foot is when there is tarsal coalition, which means small bones of the foot are born. They are born with fused bones and they need separation. So the simple test that you need to do in your OPD is called Jack test. You dorsiflex the great toe and you will see the arch reappear, or make them walk on their toes, the arch reappears. This is a flexible physiological flat foot. So when they walk with weight bearing, it looks like this. But when they walk on their toes, you will see the arch. This is flexible, painless, and nothing needs to be done. Check the mobility of the subtalar joint. If it is flexible, we have a mobile subtalar joint, and this is not a serious problem. Mid-tarsal joint mobility also you should check. So if it is painless, which is 99% of the time, nothing needs to be done. Rigid flat feet is happening only in 1% times, and they may have some treatment which is required. Suppose you have a flat foot, the parents will always ask you, what will happen? What are the consequences of a flat foot? The only consequence in the early age is distortion and wear out of shoes. The child does not have much of a problem. So you will get shoes which wear out on the inside like this, and most of the times they are asymptomatic. It is a problem of the parental concern rather than the child coming to you saying there is pain or deformity. The parents get them to you because they feel that flat foot is something bad. Sometimes, very rarely, in the older age, you can get foot strain or pain. Does flat foot become painful? Now look at this study from Army. 3,600 Canadian Army recruits. This is published data. Flat foot does not cause disability. 2 Indian studies, both by Dr. Benjamin Joseph, 1992 and 95, 2,300 children as well as adults with flat feet. And his conclusion was they are generally asymptomatic and does not need treatment. If you do need treatment, the commonest treatment is no treatment, counseling of the parents and send them home. Shoe modification, shoe inserts. A lot of people are given these or prescribed these, and that creates extreme anxiety in parents. And the last option is surgery. So the popular treatment is arch support and exercise with a silicone gel pad. And special shoes is what people ask for. But is there some evidence to it? This paper published by Dennis Renger did a study with a 3-year follow-up. They had 4 treatment groups. A control group where they did nothing. They gave corrective shoe to some people, arch support to some people, and the UCBL insert in shoe for some people. And what was their result? There is no difference between control group or treated group. What does that tell you? Asymptomatic, flexible, idiopathic flat feet do not need treatment. They do not need shoes. They do not need any wedges because they are part and parcel of a physiological variation because of laxity, and they don't really need treatment. Only those who are painful may benefit with arch supports. Treatment does not produce any better results. What is the role of surgery? Surgery is required only when it's painful, congenital, or neurological. So this is an example of a coalition. You can see that the navicular is to the calcaneum, and I'll just show you in a video. This is the normal leg. Look at the subtalar motion on the left side and on the right side. On the right side, you can see it is stiff. There is no motion, and when the child runs and plays, he gets pain. So painful flat foot, which is unilateral, this is the surgery. We have to excise the bar which was connecting the calcaneum to the navicular. So the bar is excised, and after excision of the bar, you will see significant motion in the. So there is an option for surgery for painful, stiff, flat feet. This is what you should remember. Okay, the second is vertical talus. Sometimes you have congenital flat foot. This is vertical talus, which will need correction surgically to restore the arches. Sometimes in CP, we need to do correction of flat foot for a stable base of gait. So that is called arthroaresis. We put a bone plug to prevent a flat foot. So I'll show you an example how we use this bone plug. Now this is a spastic child. Look at his feet when he walks. You can see that there is a secondary flat foot because of a midfoot break. And the hind foot is off the ground. Now this creates an unstable situation. Here we do the arthroaresis, and post-surgery, you can find that his foot is well corrected, stable on gait, and his ability to walk improves significantly. So deformity correction and giving stability for spastic flat foot. Rarely in adolescent age group, if you have a bad flat foot which is painful, we can do calcaneal osteotomy, correct the flat foot, or a triple C osteotomy and correct flat foot from this bad deformity to a more reasonably looking foot with good surgery. Miserable malalignment is a combination of torsion and flat foot. And but it is becoming best. And finally, the deformities of defects like congenital knee dislocation, club foot, hemimelia, or arthrogryposis obviously will need intervention. They are not physiological. We will need to do plasters or surgery to correct these. Foot is common as that you will see. Plaster treatment started within the first week of life will give them excellent results with a long follow-up. Thank you very much for your kind attention and stay safe in this COVID era.
Thank you so much, Dr. Sandeep Patwardhan. That was an excellent presentation, giving us very simple techniques to identify some of the most common pediatric orthopedic problems that we see in our OPD, and some simple tests to diagnose which is pathological and which is not. We'll be taking all the question answers will be taken at the end of this pediatric orthopedic session. So I request Dr. Patwardhan to be with us for some more time. And
yeah, you can just start my video. The host cancelled it.
Yeah, I request all the delegates to put up their questions in the chat box so that we can take up all the questions later. So let's now move on to our next session, which is by Dr. Samir Desai. Is Dr. Desai there with us?
Dr. Ashish will be taking this session.
Yes.
Okay. Okay. So next session is by Dr. Ashish Ranade on bone and joint infections. So I request Dr. Ranade to please start the next lecture.
Good morning. Am I audible?
Yes, yes, you are.
It's a pleasure to be here. I would like to thank IAP Pune, Dr. Sanjay, Dr. Manisha, and Dr. Kulkarni for this. So we are going to discuss few things about bone and joint infections in children, and hopefully I would like to cover the presenting symptoms, discuss what is the best way to diagnose it and what is the most effective strategy to treat it, and discuss some of the complications and long-term sequelae. So let's look at this case. A 13-month-old who is refusing to bear weight on the leg. There is pain, the child is crying with diaper change, child is irritable and having fever since last 2 days. So what is it? So before we go into what is it, we go to some basics. We will be looking into septic arthritis, osteomyelitis acute, which is defined as less than 2 weeks, and pyomyositis, which is abscess formation of the muscle. So all these three can happen simultaneously or separately. It's a diagnostic challenge, and as you know, the differential could be trauma, tumor, inflammatory disease like JIA, toxic synovitis, or tuberculosis. Usually there is history of antecedent trauma in childhood infections. Pre-existing infection might be present in some children, and the common pathogens, as you can see, as per the age groups are listed here, but still the Staphylococcus aureus forms the commonest organisms across all age groups. So usually it's the bacterial seeding due to transient bacteremia, and that could come from as simple thing as brushing the teeth. So this bacteremia will lead to deposition of bacteria in the metaphyseal region of the bone, where the circulation is sluggish, and it will cause colonization of the bacteria. This will lead to death of the cells in that area, and then bone resorption, and abscess will form. This abscess will track down underneath the periosteum and also in the intramedullary part. Usually, the physeal growth plate is resistant, and except four situations: the hip, the proximal humerus, the distal fibula, and uh, the proximal tibia, the physis is extra-articular. But in all those four places, it can go to an intra-articular extension. Septic arthritis can happen because of rarely direct contamination, or mostly it is because of bacteremia causing deposition. So this bacteremia in the joint leads to synovial cell inflammatory response and leukocytic enzymes which are released, which will lead to articular surface damage. So what are the examination findings and what is the history? Note that the pain is the commonest presenting symptoms. Almost 80% of children, they will have pain. Fever is present in 60%. Having said that, 40% children with bone and joint infection may present without fever. There will be local swelling or erythema in about 70%. And then there are other signs such as pseudoparalysis, the child is not moving the limb, in about 50% of children. So tibia and femur are the most commonest sites. Staph aureus is the most commonest organism, and antibiotic treatment is sufficient, and surgery has very specific indications. So coming back to this presentation again, what investigations we would like to do? So X-rays, usually X-rays are negative in initial stages. The lysis, the periosteal reaction will be seen after 10 days. So if we are seeing changes like this in X-ray, probably it's too late. Joint effusion is not seen, it may be diagnosed on ultrasound, and there is a role for advanced imaging. So if radiographs are normal, MRI is of immense help. It will show the anatomic extent of the disease. It will also help in surgical decision making, and usually one should try to get MRI with and without contrast, because that can differentiate between the inflammation part or osteitis versus abscess formation, because abscess formation definitely needs surgical intervention, versus if it is inflammation or then that can be treated with antibiotics. Yes, it has a downside that it requires sedation in young children. It also gives us the target area for doing bone aspiration or biopsy to get the culture. So typical, the lab tests which are done are the white cell count, which will be increased. We recommend doing ESR as well as CRP. Of those, the CRP rises earlier and it reflects the treatment response also. So the combination of both CRP and ESR has shown highest sensitivity compared to only one. And blood cultures are positive in about 40 to 50% of cases. But yes, they should be sent in all cases. Joint fluid analysis, it's difficult to do because the child needs to be sedated and it has to be done in OR. But it can differentiate between various conditions such as the rheumatological conditions, infection, and transient synovitis. So if possible, especially in tibia, one should do this culture, or the child needs to go to the operation theater and the culture should be obtained. Clinically, one can differentiate between the viral, the reactive, and transient synovitis. We'll see about this transient synovitis a little bit in detail. Viral, small joints are more commonly involved. It's symmetrical. There is less amount of fluid and modest loss of motion. So this transient synovitis, it's common in 3 to 8 years of age group compared to septic arthritis, which is less than 2. Usually there is history of trauma or viral illness, upper respiratory infection in last week or two. It's acute onset thigh or groin pain with limb and usually not associated with fever. There is slight restriction, terminal restriction of movements, and the child is able to walk with a limb. Usually it's a self-limiting condition and symptomatic treatment with ibuprofen, that is what is needed. But remember, the relapse risk is about 4%. So children can get it repeatedly. How do we differentiate this between septic arthritis? Because the treatment is drastically different. Because septic arthritis needs surgery and transient synovitis, it's just observation. So a paper out of Harvard in 1999 separated these two conditions. So if the child is having temperature of more than 101.5, if the white cell count is more than 12,000, if the ESR is more than 40, and child is not walking. So if 4 findings are present, then there is a 99% possibility of septic arthritis. 3 findings are present, then there is a 93% chance, to which later they added CRP. So CRP more than 20. So remember those 5 criteria, they are the pointer towards septic arthritis of the hip. Having said that, it's not always the diagnostic criteria, but the clinical diagnosis or the clinical examination is the best diagnostic tool. We'll come to that later why I am saying so. But yes, those criteria are very important and should be kept in mind. So what are the treatment principles in general? In general, you want to identify the organism, hit it hard with the correct antibiotic, and deliver the antibiotic to the desired site. And of course, you want to prevent the ongoing tissue destruction. So acute osteomyelitis, medical treatment is with the right kind of antibiotics. The indications for surgery are to get the specimen, the pus, the abscess drainage. If there is pus in the bone, it should be aspirated. And if there is joint extension, it should be treated. If the patient is not, if the child is not responding to antibiotics, say after 48 hours, then yes, it needs to be looked after and surgery might be needed. Treatment of septic arthritis, it's always emergency. It's open drainage to remove the pus to relieve the joint pressure. So even if the child is presenting late, yes, it should be treated surgically when possible. Rarely one can do serial aspirations with a needle if the child is very unwell or if the baby is in ICU, when it is not possible to undergo open aspiration. So in general, one should get blood cultures, blood results, aspirate, debride if indicated, send a specimen for gram stain and cultures. And what about antibiotics? How long we should give IV, how long we should give oral, what's the duration, how do we monitor? So the trend is towards using shorter course with early transition to oral antibiotics. There are a number of studies in last 10 years which have shown that prolonged IV therapy is not necessary and one can switch to oral antibiotics at an early stage, provided we know the culture sensitivity and we are closely monitoring the child. So the duration for septic arthritis is approximately 3 weeks and 4 weeks in osteomyelitis. But remember that one should have the right bacteriology, we should know the susceptibility, the clinical response and adherence to the strict antibiotic regimen. And one should also need to monitor clinically as well as lab parameters. So coming back to the case 1, this 13-month-old who was having temperature, he was crying with diaper change, he underwent X-ray which was normal, his counts were raised, his CRP was slightly high, and using those criteria, now you know that this is septic arthritis of the hip. There was effusion in the hip joint and he underwent incision and drainage emergently. His cultures grew staph and it was treated in time to avoid the complication like this, the avascular necrosis. Coming to another case, a 3-year-old girl who is having fever since 3 days. She's not putting her left foot down. No history of any injury or upper respiratory illness. Her labs show increased count, her CRP is high, USG shows no effusion. So using the Coker criteria, is it septic arthritis? Well, the hip examination was not particularly painful and there was no hip effusion. So the possibility of hip septic arthritis is less. So she underwent bone scan which showed increased uptake in the left ilium. So subsequently, a MRI was done, which has shown abscess in the pelvic muscles and osteomyelitis of the iliac wing. So subsequently, that was treated with surgical debridement and antibiotics. Okay, so another case of a 15-month-old girl. She's having fever 102 since 3 days. She's not walking. Her leg movements are painful. It's hard to know how the hip movements are. She's crying when you touch her leg. Her counts are raised. There is minimal swelling over the thigh. There is hip joint effusion. X-rays are normal. So again, using the criteria, is it septic arthritis? Well, there is pain over her thigh, there is swelling. So yes, it could be septic arthritis, but it could be something more. So these are the ones where one should do MRI. So MRI was done, which showed uh, there was no effusion. There was effusion which was sympathetic, which was not enhancing with the contrast. There was nothing in the knee or hip. And so this was quadriceps pyomyositis. There was no bone involvement, so there was no osteomyelitis, and there was no involvement of the joint. So this was drained, and first the culture grew MSSA. So she had IV antibiotics for 4 days. Her pain settled, her fever settled, and she was switched over to oral antibiotics for another 10 days. So is it always hip arthritis? So a study done I think this is out of Vanderbilt, it showed that a child presenting with hip pain, almost 30% they have pericapsular pyomyositis or abscess of the pelvic musculature, and the only septic hip was present in about 15%. Transient synovitis was again a major player, almost 40%. So one has to be very careful that we are not missing out these pelvic infections. So they developed a protocol that when one should do MRI in a child with septic arthritis. So if the child is older, more than 4 years of age, if the symptoms are there for more than 3 days, if the CRP and counts are high, then if 3 or more of those factors are present, then one should consider getting a MRI scan. Look at this case. I'm sorry, a 3-year-old who has refusal to walk, painful leg movements, counts are high, CRP is sky high, ESR is very high. You can notice that there is swelling over here, and purposefully I have shown this picture to show that the hip and knee movements are symmetrical on both sides, which essentially tells us that probably the joint is not involved. And that's why I said it's the clinical suspicion for septic arthritis more than criteria. Because if you apply the criteria, yes, this is septic arthritis of the hip, but it is not. So his X-rays were normal. He had ultrasound of the hip and knee, which showed effusion. So he was admitted somewhere else, and he had IV antibiotics for 4 days. But his fever was not getting better. The child was very toxic, sick looking, and he was shifted to us on day 6. So MRI was done. MRI showed that there is abscess on the medial as well as lateral as well as anterior side. In addition, there was bone involvement. The osteomyelitis was involving whole of distal femur as well as the middle femur, the hip and knee. There was no enhancement on contrast MRI. So essentially, there was no septic arthritis of the hip or knee, and a diagnosis of acute femoral osteomyelitis with intramedullary abscess with thigh abscess without involvement of hip and knee was done. Essentially, treatment is surgical. We did debridement through a bone window. The thigh abscess was drained. It grew MRSA. He was given IV vancomycin and then shifted to oral linezolid thereafter. A regular follow-up was kept for this child because it has high risks of recurrence of infection, developing a pathological fracture, growth arrest, and deformity and shortening. So this is the protocol which they have described in 2014. So these are the Finnish guys, Peltola and all, who have swung the pendulum for shorter duration with close monitoring. So what are the complications? Systemic sepsis is the dreadful complication. Recurrent infection, chondrolysis, that's destruction of the articular cartilage of the joint, avascular necrosis, growth disturbance. I had this child, 12-year-old, who had infection in the distal, in the proximal, distal tibia, the MRSA, and he developed DVT, and that led to septic pulmonary emboli. He developed PE, he had bilateral pleural effusion, he developed epidural abscess, and very scary scenario. I mean, fortunately, he survived, but these are the really tough ones. It can lead to avascular necrosis of the hip joint, and still we are getting children like this, a chronic osteomyelitis presenting with a pathological fracture and essentially dead bone leading to a gap. So all this is definitely preventable if treated early and if the osteomyelitis is treated in the earlier stages and picked up earlier. Chronic osteomyelitis in an 8-year-old girl, she had multiple surgeries, so that was treated with a local drug delivery system. It's essentially a salt of calcium sulfate in which we pack vancomycin, and that elutes the antibiotic locally and takes care of the infection in chronic osteomyelitis, and it gets resolved over a period of time. So it's possible to use these kind of local drug delivery systems in addition to systemic antibiotics. Here is an example what happens if a child gets childhood infection. So this 8-year-old had a neonatal septic arthritis, which led to growth arrest of her proximal tibia. So she's short by 4 centimeters and she developed varus deformity. So she has to undergo a complex procedure for leg lengthening and deformity correction. And since she is only 8, she is likely to need further surgeries because the leg length difference is going to get worse as she grows. So it's not always infection. Sanjay will probably remember this case. This 6-year-old presented to us with fever of 103 for 4 days. He had hip pain, he had back pain, he was refusing to walk. His hip movements were painful, tenderness over the right hip and spine. His neurology was normal. Very sick looking child. His investigation showed anemia, his counts were normal, although his CRP was slightly raised and his ESR was raised. There was no hip joint effusion, blood culture showed no growth, but the child refused to walk. So his x-rays were inconclusive. We did a bone scan, which again didn't help us. Then we thought that probably showing a vertebra plana. So we did a skeletal survey and thought whether it is eosinophilic granuloma, because his skull was also showing mottled appearance. But still that could not explain why he's not walking, why he's so sick. So we did a MRI. There was no cord compression, but we noticed that the 2 vertebrae were wedge shaped. So we did a transpedicular bone biopsy. Again, the histopathology was inconclusive. There was no growth, uh, nothing suggestive of TB. So he underwent a iliac crest bone marrow biopsy, and it showed a B cell lymphoma, and he was handed over to oncologist for further care. So it's not always infection, it could be something else. Always remember that in mind. So in summary, Unless proven otherwise, localized bone pain and fever, it's osteomyelitis. Consider obtaining MRI for every suspected case of acute osteomyelitis. Acute osteomyelitis without abscess can be treated with antibiotics, but yes, one should know what organism is. Always do culture and biopsy. Septic arthritis is a surgical emergency and it is common in less than 2 years of age, and while osteomyelitis is seen in older children. And as I said, the clinical suspicion and very high index of suspicion is the key to diagnose this condition at an early stage. Thank you.
Thank you, Dr. Ashish. That was an excellent talk on bone and joint infections, telling us some of the common conditions that we can identify and also telling us a very rare case wherein it may not be infection and how to identify and go to investigations and treatment in such cases. Thank you very much. I request you to be with us for we'll be taking the question answers at the end of this pediatric orthopedic session.
Thank
So
you.
now we move on to the next lecture by Dr. Sameer Desai, which is on common childhood injuries and fractures. So over to Dr. Sameer now.
Yeah, good morning, everyone. I hope you can hear me and my slides are visible.
Yes, sir.
So I'd like to thank IAP for organizing this program. So I'll be speaking on common injuries and fractures in children. So let us see what I'll be covering in this lecture. So I'll be speaking on sports injuries, newborn fractures, acceptability criteria and remodeling of fractures, fractures that are missed, fascial injuries, what are the problems that are usually associated with them, pulled elbow, which is also very common in your practice, fractures with emergency, elongating rods that are available, and fractures in special situations like cerebral palsy and infection. So let us take it one by one. So sports injuries, they can be varied according to the sport that the child plays. You can get osteochondritis dissecans, medial epicondyle fractures, shoulder instabilities, clavicle fractures, ulnar collateral ligament injuries, ACL injuries in football players and basketball players, and stress fractures. But what is important as clinicians that we should know is how to prevent sports injuries. So all children should have a 2-day break every week to allow muscle to recover. So don't let them play the same sport all 7 days of the week. Children should ideally play two different sports to train different muscles, that is cross training. For example, my daughter does skating and swimming or skating and badminton. They should also have off seasons like adult athletes. So they should have a break at every year for at least a month. Strength training is advised in adolescent age group. And you must remember that female athletes in their teens are more prone to injury. So this is very important and you should advise parents accordingly. So though this is not a fracture, you will get a lot of children coming to your OPD who complain of painful lump below the patella. And this is usually seen in children who are playing jumping sports like basketball. What is the usual treatment that we advise? Usually I request them to take some rest, apply ice and analgesics, and the children do very well. The next condition is Sever's disease or calcaneal apophysitis. You get children typically in the age group from 10 to 12 coming with heel pain. These children are usually involved in running and jumping sports. So what advice do you usually give them? We tell them to take rest, immerse their feet in warm water every day, and do some TA stretching exercises. This typically shows a waxing and a waning pattern. And so I tell all parents that when it is painful, ask your child to take rest. And when it is not paining, he can play all sort of sports. So Sever's disease is another common or calcaneal apophysitis. Everyone should know how to apply a simple splint in your OPD. A splint is something which is non-circumferential. If you see a compound wound, do dressing. If you see bone jetting out, don't throw the bone away. Just put some saline gauze over it, apply a bandage, and send it to your nearest orthopedic surgeon. What is important is that these ready-made splint materials are available in market, and I feel that all clinicians should have these plaster materials in your clinic. So what they are ready-made fiberglass and padding wrapped in mesh layer, and what you need to do is that just wet it in water and wrap it around the limb using a bandage. So you don't need to actually make slabs. These are ready-made slabs and you can use them. So you do keep them in your OPD and these are readily available. Some of the common methods of immobilization or splinting. Finger injuries are very common in children. So this is a type of finger splint that you can use. Another common injury is injury to the fingers, especially when the child is playing basketball or cricket, and they also have phalanx injuries or phalanx fracture. So what you can do is that simple buddy strapping. So just strap them and for about 3 weeks and the child does very well. Or if the child complains of shoulder pain, you can give a simple shoulder immobilizer. So these are simple splinting methods. Especially buddy strapping is one of the commonest method that you can use in your practice. Fingertip injury. These are usually seen in toddlers. They have a very bad habit of inserting their fingers in the doors and they come to us with this nail injury. Sometimes these children may have nail bed injuries, but usually what is required is a simple K-wire and CLW suturing, and these children do very well within 7 days. So fingertip injuries are also very common in toddlers. So let us look at the acceptable criteria for fractures. This is very important because you don't need very accurate alignment in children because they remodel very well. So depending on the age, in a child who is less than 8 years old, you can accept angulation up to 10 to 15 degrees and shortening up to 1 centimeter. And in a child who is more than 8 years, up to 5 to 10 degrees and up to 1 centimeter of shortening. This acceptability criteria will change according to where the fracture is, how close to the physis the fracture is, what is the age of the child, and what is the growth remaining. And also it is important to measure the true fracture angulation. This is because you must take it in the correct orthogonal plane. Otherwise, you might miss the amount of angulation. So younger children will have more growth remaining, so you can accept more degrees of malangulation. So let us see this example. This was a 6-year-old child. This was the malalignment after the plaster removal. But over 2 years, you can see that this fracture has remodeled very well and the child has got full range of motion. What about newborn fractures? So these are especially seen in children who are chubby with history of difficult labor. In a newborn child with femur fracture, the commonest method for treatment is a Pollock harness. And in a newborn child, the acceptability criteria is up to 60 degrees of angulation and up to 2 centimeter of shortening. So this is the amount of malangulation that you can accept. So you can treat with Pollock harness or you can also treat this child with a hip spica. You can see the amount of overlap in this child. But over a period of 1 year, you can see that this fracture has remodeled very well with very little angulation. So you can treat newborn femur fractures with either Pollock harness or hip spica. The next thing to be remembered is what not to do. So this usually happens in an NICU sitting. This child had fractured femur and they applied a hand splint. Initially it was applied over the femur, but it has slipped down and you can see that it is clearly not immobilizing the femur. Usually what happens is that the proximal femur is flexed, abducted and externally rotated. So you must align the distal to the proximal. Another thing that you should not do is that you should not splint it in full extension. If you do this, then this is what is going to happen. You can see that this fracture has malunited in almost 90 degrees, and this child is going to have some deformity and shortening. So you must align the distal fragment to the proximal fragment. So pollic harness or hip spica. The next common fracture is fracture humerus. This is especially seen in chubby children, difficult labor, shoulder dystocia. So the gynecologist had to pull the child a little bit and this child had a fracture. So what simple thing you can do? What you can do is a simple shoulder arm strapping. You can use a simple bandage, micropore sticking. What you should remember is that you should never use a dynaplast because their skin is very, very delicate. So you can injure the skin. And remember to change this every week. This is because otherwise it starts smelling. So simple shoulder chest arm strapping in a child who has sustained a fracture humerus. And you can see in 2 months, this is the amount of callus. And at 8 months, you can hardly see the fracture and excellent remodeling. So fracture humerus in newborn, simple chest arm strapping with a bandage. Clavicle fracture. Purposely, I have put this X-ray which is showing exuberant callus. So usually, this is missed in an NICU setting. What you should not miss is it should not be missed with OBPP. What has happened is that if there is a clavicle fracture associated with OBPP, there is a high chance that this child has got a very severe injury. Also, I remember a story where in an NICU setting, the OBPP were with OBPP, the clavicle fracture was missed, and the parents were unhappy that clavicle fracture was missed, though nothing had to be done for the clavicle fracture. So remember, don't miss clavicle fracture with OBPP. In an older child, especially toddlers, the parents will come to know, or they'll come to you only when they notice a swelling. So by this time already the fracture has united. You don't need to do anything. So once you start feeling a lump or a swelling, you can be assured that the fracture has united. You tell them that this swelling is going to disappear over 15 days to 3 months. So don't worry. If you get an older child, you can give a simple sling or a figure of 8 viscose splint, which is readily available. So don't miss clavicle fractures in NICU. This was the take-home message for this fracture. Another common fracture is torus fracture. This is often missed by parents. You need simple splint for about 15 days and may need a plaster if it is very painful. So usually parents come to us telling us that the child had a fall. It was 8 days ago and then he had slight pain. But the child is moving the limb. So usually if the child is moving the limb, we don't give plasters. These fractures do very well. Importance of how to read a elbow X-ray. This is very important. This is because the different centers of ossification are going to appear at different times. So look at this medial epicondyle over here. You might feel that this is a fracture, but this is a normal phenomena. Or look at this. You might feel that this is a fracture, or this is the radial head. You might feel that this is a fracture. So let us see at what time the centers appear. So the mnemonic is CRITOE, C-R-I-T-O-E. So capitulum for C. This will appear usually at 1 year. R for radial head, appears around 5 years. I for internal epicondyle or medial epicondyle, which will appear at 7 years. T for trochlea, which will appear at 10 years. O for olecranon, which will appear at 10 years. External epicondyle or lateral epicondyle, which will appear at 11 years. So you should also remember these things because sometimes if you're not able to see this, then there might be an incarcerated fragment. So remember CRITOE and 1, 5, 7, 10, and 11. So this child was sent to me mentioning in the referral note that this child has got elbow dislocation and please treat it. But observe this, we did a sonography, and this is what we found, that this is usually a fascial slip. So distal end of the humerus has slipped. So this is not a elbow dislocation. This is usually seen in children, newborn children or children less than 1 year. What is usually required is a chest thumb strapping. So this is not a elbow dislocation, but this is a fascial slip. You may also have to rule out hypothyroidism in these children. Another common condition, child has come to your OPD, the parents give you a history that there was a pull and they've heard a click. So this child is having a pulled elbow. The child will not be using the affected limb. Elbow is in extension and the forearm is in pronation. The child is distressed on elbow movement. What is important to see is that there is no swelling, deformity or bruising. Many a times it has happened that a child was referred to me for pulled elbow. They have tried 2 or 3 attempts, but they were not able to reduce it. But the child had elbow swelling and it turned out to be a undisplaced supracondylar fracture or a lateral condyle fracture. So remember, a child with pull elbow will not have any swelling. And what is the role of X-ray? Usually we don't do X-rays for children whom we are suspecting pulled elbows. This is because the diagnosis usually is straightforward and we just have to do a reduction maneuver. So what is the pathology in this? Usually we say that the radial head is dislocated, but actually what has happened is that the annular ligament is interposed. So let us see how to reduce pulled elbow. First, you should be able to palpate the radial head. So the technique for that is that you palpate the lateral epicondyle, which is very easy to palpate. It is the most prominent bony point at the lower end of the humerus. And just below that is the radial head. So the forearm will usually be in pronation. So I have applied pressure over the radial head. Then you supinate the forearm and then you flex the elbow and you will hear a click. So remember, until and unless you hear a click, it is not reduced. So you can give 1 or 2 attempts and you will be successful. So this is just to show you a small video of how to reduce it. So this was a child. We are just looking for swelling. There's no swelling. And it's so that is the lateral epicondyle. Just below that is the radial head. So now we are going to proceed with the reduction maneuver. We have applied pressure over the radial head. We have flexed the elbow and I have heard the click. So immediately I was quite sure that I have reduced it. And you can see that within 5 minutes, we call it like jadoo. Within 5 minutes, the child has started using the limb. And you must remember that if you have successfully reduced it, the range of motion should be normal. The child should be pain-free and should be playful. So if the child is not moving the limb, remember that you have not been able to reduce it. You can try it again, or then you can refer it to a pediatric orthopedic surgeon. So now moving to lower limb fractures. This was an adolescent with hip pain, came to our OPD with external rotation gait. Child in this case was not obese, but usually these children are very obese. So this child had slipped capital femoral epiphysis. So this is usually associated with hypothyroidism, obesity, endocrine abnormalities, diabetes, and important thing, very big study from Vellore showing that they have vitamin D deficiencies. So slipped capital femoral epiphysis should be suspected in a child who is obese around 10 to 12 years of age coming with hip pain. This is what we had to do. We put CC screws, and this child who came to me after 3 years, look how tall he has grown. He did not have any endocrine abnormalities when we did his blood test, but you can see that over a period of time, he's grown that tall. So they could be having some subtle hormonal abnormalities which had led to the slip. Another common fracture, that is fracture shaft femur. what you could do is that there are two ways to treat this. Either you can treat it with a hip spica or a titanium elastic nail. So depending on the age, depending on the severity of the trauma, we decide the modality of the treatment. Another common injury is a toddler fracture. This is a short spiral fracture. You will get a child in your OPD who's had a twisting injury. You might feel or see some swelling over the tibia, and you should do an X-ray because you are going to see this small spiral fracture. So this is very common. We call it as a toddler fracture, and this does very well. Also, lower end tibia fractures are common, especially if there is a blunt trauma, and this child was treated in a plaster and this child remodeled very well. So now let us look at fractures that are difficult to diagnose or that are missed. This was a child with an elbow injury. Looking at the X-ray, it looked near normal, but special X-rays were not done. And after 1 week, when an X-ray was done, you can see that this child had a lateral condyle fracture, but they refused treatment. And you can see that after 3 months, this has gone into delayed union or non-union, and this fracture is very difficult to treat. So a simple looking fracture, not necessary. You must do follow-up X-rays. If you have not sent the child to us, please do repeated X-rays. There is a chance that this child may have undisplaced lateral condyle which may displace later. So you must do repeated X-rays. Another fracture or dislocation that is missed is Monteja. This child had clinically just looked like a ulna fracture, but they did not look at the radius. Normally this line should pass through the capitulum. This was missed, and in this child we had to do a osteotomy of the ulna and an open reduction to put the radial head back. So some fractures can be missed, so you must be aware of these fractures. Another important thing that I'd like to draw your attention to is why you should take two views. So I was called to PICU. This child had a history of fall from height. We do get a lot of children with history of fall from height. And this child was awake but not moving the right lower limb. And the only suspicion was if you look at the physis of the femur on the right hand side. So we asked for a lateral X-ray, and this child had a physial injury. So you can see that if we would not have taken a lateral view, we would have missed this fracture or this dislocation. So you must take two views, AP and lateral. Don't rely on one view. So if there is history of fall from height, what are the common X-rays that you must take? You don't forget to take both AP and lateral view. You have to take views of the cervical spine, AP and lateral, dorsolateral spine, pelvis with both hips, both lower limbs, and of course calcaneal X-rays. So don't forget, this is the set of X-rays that you must take if there is a child who has a history of fall from height. There are some emergency fractures too, like supracondylar fractures with neurovascular injuries or fracture neck femur, which need urgent treatment, and they're also difficult to treat. So let us see some fractures in special situations. So children with CP, they're prone to fractures. They have vitamin D deficiencies and other deficiencies. So this child had a physial slip. The child was undergoing physiotherapy, and you can see that over 4 months, look at the amount of callus. So this is actually the hematoma that has calcified after we gave vitamin C. So remember that all children of CP who are GMFCS 4 and 5, that is who are just lying down, not moving around, those who have got poor diet, have scurvy. So you must give them vitamin C, and otherwise they will have these slips, which is very common. And you should also give them vitamin D and calcium supplements. So cerebral palsy, remember, they need vitamin D, vitamin C, and calcium supplements. So fractures you'll also see with osteomyelitis. This child had fracture of the proximal tibia with osteomyelitis. What we had to do is debridement local antibiotics. We immobilized it in plaster, and this fracture healed, though with some deformity. So another common condition is osteogenesis imperfecta with fracture. So what is now done is that we have got these elongating rods which we can put, so that we don't need to change these rods very frequently, and there are male and female component, they slide over each other and it elongates as the child grows. So in osteogenesis imperfecta, we can use these elongating rods or FD rods. Finally, coming to fascial injuries, they're classified as type 1 to type 5, but you can see over here that type 3, 4, and 5 are the fractures that are going to cause problems. They could have growth arrest, they could have valgus, varus deformities. So long follow-up is required in these children. So this is just to show you an example. This child had a distal radius fracture, but was treated with K-wires, and over a period of 2 years, you can see that this child has developed fascial injury. So long follow-up is required in fascial injuries, and these injuries are usually difficult to treat. So to summarize, children's bones have excellent remodeling potential. Give medicines to relieve pain. I've seen a lot of times children are not given painkillers. So you must give them painkiller so as to relieve their pain. And remember, if the child is pain free, he will play and he will not trouble the parents. Be aware of fractures that can be missed. Pulled elbow is very common, and as a pediatrician, you must know how to reduce a pulled elbow. It's very easy. Supination maneuver and flexion maneuver. Special conditions like cerebral palsy, osteogenesis imperfecta need special considerations. Don't forget to get whole length views, because you will likely to miss fractures, especially in PICU setting. Long follow-up is required in fascial injuries, and usually in children you don't get stiffness except in intra-articular fractures. Thank you very much.
Thank you, Dr. Samir. That was an excellent presentation, very informative and to the point. We are well within time, so now we'll go on to our question answer sessions. I think the first question is to Dr. Patwardhan. Can you demonstrate common deformity, the screening tests for these deformities to be done by a pediatric clinician, Beighton score, Galeazzi, and torsion? Is Dr.
I think
Patwardhan there with us?
yeah. Can you see me?
Yeah.
Yeah, so I have actually answered that online also, but I'll just highlight again. If you're looking at a child and examining his lower limbs, the first thing that you need to do is examine him supine. The patella should be facing forward. So make sure that the rotation is corrected. The kneecap should be looking at the ceiling, parallel to the ceiling. It should not be lying externally rotated or internally rotated. And with that position, make the knees just touch each other. In that position, you can look at where the ankles are. If you find that there is a big gap between the ankles, then in that position, you measure the intermalleolar distance. That is for genu valgum. If it is a bow leg, you measure the distance between the knee, the intercondylar distance. Then you look at the foot, see if there is metatarsus adductus, which means the deformity is in the foot rather than in the hip or the knee. Then put the child prone. When he is prone, from the top, you look at the alignment of the foot to the thigh. That is called the thigh foot angle. If it is not going outwards, then the child has internal tibial torsion. Then look at internal rotation in the hip. Try to rotate the hip and see how much it touches the bed. If it completely touches the bed, he has excessive femoral internal rotation. That is why he is walking in toe and will be a W sitter in all probability. Then you can examine his upper limbs, and if he demonstrates signs of hyperlaxity, which means elbow is in recurvatum, the thumb touches the forearm, the fingers go parallel to the forearm in dorsiflexion, then these are signs of hyperelasticity. So you do some measurements and you do some clinical examination. Most of these are painless. Anytime you have a painful deformity, you will need an additional investigation.
Okay, thank you, Dr. Patwardhan. I think the next question is for Dr. Ranade. What are the common bugs in osteoarticular infections in your experience, and what is the percentage of MRSA?
So, as discussed, commonest is Staph aureus, MSSA, which we are seeing. MRSA, I haven't looked at, there is no sort of epidemiological data, but it's less than 5 or 10%. It's not very rampant, but yes, Staph aureus is the commonest one, which we get.
Any other bugs which you see other than the staph?
Rarely.
So if you have an NICU baby, most of the times you will get a gram-negative Klebsiella or something. And if it's an open wound, compound fracture, then you look at polymicrobial infections. But what I wanted to also point out here is that Ashish will agree, and Samir, I am sure, that subacute osteomyelitis with osteolytic lesions, TB is quite common, more than you think. We are seeing a lot of osteoarticular tuberculosis in children.
Yeah, I would agree. I have
Yeah.
seen TB even in a 2-year-old. So,
And
who had
if it is epiphyseal osteomyelitis, I would think of TB and fungal osteomyelitis first. So those are the ones they present like that.
Okay, and I think the next question is also to you, Dr. Ranade. What is the percentage of clindamycin resistance in staph, which we isolate from bone and joint specimen?
Yeah. So
How much is the?
no, I don't know answer to this, but we are not Clinda. Most of the reports I'm seeing that it is sensitive to clindamycin, but there are limitations to use of clindamycin because, as far as I know, we are not getting oral clindamycin. It's available on the IV. So that's not our preferred drug. So usually we prefer ceftriaxone, which is single dose IV. And when one needs to switch to oral, we go to linezolid, which has shown to have good bone penetration. So I know clindamycin is a good drug, but we don't have that option available.
Okay. What is the
Another
incidence?
question.
Okay, I think that is. Yeah, continue, Sanjay.
One question from my side. You discussed regarding shifting to oral antibiotic. So does CRP and ESR guide us in any way when to shift to oral antibiotics?
Absolutely. So we start with IV when the child is afebrile for at least 48 hours. When the labs show a downward trend after, say, 1 week or so, or the CRP has returned to normal, clinically the bone pain has reduced, then I think that time, typically I would wait till CRP is normal. So that may take about a
One,
week or 10 days.
right.
Okay. Can I go to the next
Question.
question, Sanjay? You have
Yes,
anything?
yes, please. Yes, please.
Okay, there is one question by Dr. Revati regarding ligamental injuries, particularly knee joint. How significant it is for persistent knee pain in later life, and when should it be treated?
So by ligamentous injuries, I think so you are mentioning about ACL and PCL. So
Yeah, I
usually,
think she means that.
yeah. Nowadays, arthroscopy surgeons are even treating children with ACL reconstruction as young as 11 or 12 years old because they have these fascial sparing techniques. But usually they prefer till the time the physis is nearly fused. So I had a basketball player who was advised rest and she refused to. She said, I don't want to take rest to do my ACL. So she was as young as 13 years old. So depends on the patient, depends on the status of the physis, depends on the skill of the surgeon. So usually they wait till the physis is fused for ACL reconstruction.
Okay, and which painkillers are safe to be used in children?
I usually give Ibugesic plus or Combiflam, and usually I have not had any problem. But you can, if the child is very small, you can give simple crocin drops.
Manisha, on a lighter note,
Okay.
as orthopedic surgeons, we know only 3 painkillers: So you are the
Right.
one who should tell us what is safe.
Correct, correct.
We don't use anything more than ibuprofen, paracetamol, and naproxen sodium.
We use the same.
So then you know the answer.
Yeah. But I have to ask the question which comes up. Okay, I think next question is to Dr. Ranade by Dr. Millen. Stress fractures in adolescent and preventing it and its treatment.
Okay, so stress fractures are sort of fractures which develop in, there are two causes. Either it is because of repetitive stress or repetitive injury to a normal bone. So child has started playing something new. I had a child who started practicing taekwondo and started kicking and breaking the tile 40-50 times a day and developed stress fracture of her distal tibia. So that is one cause. Or the other cause is there is some underlying bone pathology, bone softening conditions. Commonest is osteomalacia, where they develop a stress fracture typically on the medial side of the femur tibia, which heals with treatment with vitamin D and calcium. So they need metabolic workup, activity modification, rest, and one should also try to identify if there are stress fractures anywhere else in the body. A bone scan is helpful.
Okay. Thank you, Ranade. I think that's the many questions that we had. Uh, any other question anybody would like to ask? Okay, there is one more question which has come up. Heel pain with normal X-ray. I mean, approach to heel pain. Is there any other reason beside calcaneal apophysitis? It's
Commonest,
I think
yeah.
yeah.
The commonest cause, as I've mentioned, is calcaneal apophysitis. It could be, I mean, of course, you should rule out thorn injuries. I've seen children who have had a thorn injury over there, or sometimes a very small abscess. But the commonest cause is usually calcaneal apophysitis, and they do very well with simple rest, hot water fomentation, and usually and some analgesia.
Okay, I do not get this question, but the question is treatment of shin splints.
In splints.
Acha,
Same thing.
splints.
There must be stress fracture of the tibia. Ashish has already answered.
Yeah.
So there is another cause for that which they're talking. It's called it's like a compartment syndrome. So there is no pain, but when they start doing the strenuous activity, they start running, and as their tempo increases, the pain increases because of the metabolites releasing in a tight compartment. And when they rest, the pain goes away. So as Sandeep was mentioning, these are the two commonest causes: stress fracture and
I,
this
I have
compartment.
to just make a comment here. All these conditions, what is happening is now we have a big society now of um, aggressive sports trainers as well as aggressive parents who are pushing their kids with soft bones to too much activity. I think it is important as pediatricians for you to counsel them to not to flog a dead horse. Their children are in the growing age with soft bones, and everybody wants them to become the next cricket star or the next Anya Mirza. And when you tell them no, they have to stay off sports, they look at you angrily as if you have said some bad word to them because they feel that you're compromising his or her career. So I think as pediatricians, when they come to you must. I feel all these growing pains and all of them have a subtle psychological bias to them. There is always an underlying cause why they are being pushed into doing so many things or overdoing things, or is the trainer responsible because they also want to. The physiology might be different, the bone quality might be different, but they'll make them run 100 laps. And we do get compartment syndrome, we get muscle pains in swimmers, we get higher ACP. I'm sure Ashish and Samir also have seen that happen. So I just wanted to just highlight this point to all clinicians that just talk to the parents and get their psychology behind that also treated, because it's not good to treat everything with painkillers.
Exactly.
So
Very
you mean to
valid.
say there is some age-specific selection of the sports that we should be advising?
Yes, there is definitely, no, I won't say age specific, I would say physiology specific. Some body postures are not cut out for certain things. Children who have stiff joints, if you ask them to do gymnastics, they'll probably break a ligament somewhere. Or people who have hyperlaxity, if they do extreme sport, they'll get a dislocation.
Okay.
So
Yeah, I
that does
agree with
happen.
Sandeep, yes, because you see, my elder daughter is very flexible. She does a lot of sports. My younger one is not flexible. So if you ask her to do the same sport, she is not ready. So you should also leave it on the children a little bit. So that's why I had put up a slide mentioning how to prevent these sports injuries. And this is what is very important.
Very valid points. So all I think pediatricians should talk about these overuse injuries. And another thing which we are seeing is they play sports to a competitive level. Like they would play badminton 5 days a week, then evening they do taekwondo, and in between they are swimming. So I think
Yeah.
that is a lot to ask, right?
Somewhere something is going wrong.
Okay. Any more questions?
I think the
I
questions
don't.
are done. And I would like
Yeah,
to compliment the pediatric orthopedicians. They have been perfect sticking to the time exactly. So we are 5 minutes
absolutely.
over time. Fantastic job. Thank you and excellent lectures from all the experts. Thanks a lot, Ashish, Patwadan sir and Samir. And I think we can shift to the next part of our CME, that will be pediatric surgical.
Thank you.
Yes.
Bye.
Thank
So
you.
let's move on. Thank you
You
to
are welcome
all.
to stay online and listen to the pediatric surgery lectures as well.
Sure, we'll ask questions also.
Ask related to only pediatric surgery. Yeah?
Yeah. No, we have a lot of overlap, especially when treating infections. So
So let's move on to the pediatric surgery part of today's webinar. And we have eminent consultants with us today, Dr. Dasmeet Singh, Dr. Dhananjay Vaze, and Dr. Meenakshi Bhosle. So the first lecture is by Dr. Dhananjay Vaze on management of pediatric surgical emergencies, that is acute appendicitis, intussusception, and foreign body ingestion. Can I have the slide of Dr. Vaze, please? Yeah, thank you. So Dr. Dhananjay Vaze is an associate professor at D.Y. Patil Medical College, Pimpri Chinchwad, and is a panel consultant at Inamdar Hospital and at Dinanath Mangeshkar Hospital, Pune. So over to you, Dr. Vaze, sir. Okay, Sanjay, can I introduce all the consultants at the same go? Hello? Sanjay?
Yes, please go ahead and complete it.
Okay. So our next expert is Dr. Meenakshi Bhosle. Can I have the slide, please?
Okay, let us switch back to the first presenter.
Is there some problem in sharing the slide? Can I introduce Dr. Meenakshi?
Just give me half a second.
Okay.
Dhananjay, can you just stop sharing screen for a second? Okay, I think we'll I'll just share the screen.
Yeah, sure. Okay, there we have. So Dr. Meenakshi is presently Associate Professor and Head of the Department of Pediatric Surgery at BJMC. Pune, has performed thousands of surgeries, major and supramajor, has 48 research publications in national and international journals and 3 book chapters and 5 book publications to her credit. Her notable publications being Pediatric Surgery Simplified, a CBS publication in 2019, and Japuyat Nisarg Niragas Balpan at Rohan Prakashan, year 2020. She is a part of ICA NCL group of IAP and is recognized network provider of the Indian Child Protection Medical Profession Network in Maharashtra. She is an advisory board member for Muskan Foundation for Child Protection. He has received prestigious Loksatta Durga Award in the year 2019 for operative work and prevention of activities related to child sexual abuse. She is a recipient of Pediatric Surgery Awareness Award from IAPS for the year 2019 and 2020. Our next expert today is a well-known figure, Dr. Dasmeet Singh, who is a professor and head of Department of Pediatric Surgery at BJ Medical College and Sassoon Hospital, Pune. Distinction of conducting many live operative workshops. He is the first to do thoracoscopic or keyhole open heart surgeries in India. Has written many chapters in various books in pediatric surgery. I think we'll start the session today. The first lecture is by Dr. Dhananjay Vaze, as I said, Management of Pediatric Surgical Emergencies. So over to Dr. Vaze, sir.
You need to unmute, Dhananjay.
Okay. Can I share my screen?
Yeah, please.
Yes, we can. We can see.
You can see my screen there.
Yes, yes.
Yes. Give me a today, hello everybody. I will be speaking on acute appendicitis, intussusception, and foreign body ingestion. So these are the 3 topics. I would just touch on all the 3 topics and try to give you insight and whatever goes into my mind when we have to approach or how we have to approach this patient. Coming to acute appendicitis. Physical examination of acute appendicitis is the most important parameter of diagnosing acute appendicitis, and it has to be the right iliacus of pain or the tenderness is one of the pathognomic features of acute appendicitis. Coming to history. Hello.
Patwardhan sir, you need to mute.
Hello.
Yes, sir. The disturbance has been removed. Can you please continue?
You need to share the screen again.
Yeah. So it is the RIF pain on the tenderness that and with anorexia, vomiting, and fever that basically determines the presence of or point towards the presence of acute appendicitis. Now, after once
screen is not visible.
We are not able to see your presentation. Please share your screen.
Okay, sorry.
Dr. Vaze sir, we are not able to see your.
Yeah, I'm doing it.
Yeah.
Yes, now it is visible.
Can you see it now?
Yes, yes.
So this is the physical examination is very important for diagnosing acute appendicitis, and then invariably and we going for ultrasonography of the abdomen in order to confirm or to refute the diagnosis of acute appendicitis. The most important advantage of ultrasonography is it is readily available and it is non-invasive and it confirms diagnosis. But the problem generally which people look towards it is as being observer dependent. So many people are of the view that the computed tomography has better sensitivity or specificity in diagnosing acute appendicitis than ultrasonography. But let me tell you that in each and every case of acute appendicitis or a suspected case of acute appendicitis, computed tomography is not required because it will be unnecessary utilization of the resource and unnecessary radiation dose to the child. So we have effectively we have to go in for with this 3CU mechanism. That is, the first C will be the physical examination, the second C will be the ultrasonography, and the third C, if these two C's suggest appendicular perforation or an inconclusive kind of diagnosis, then a computed tomography is has to be applied for acute appendicitis or in the diagnosis of acute appendicitis. Also, along with it, we have to do some corroborative investigations like hemogram. Leukocytosis is invariably present in cases of acute appendicitis, and count more than 15,000 per cubic millimeter is suggestive of a perforation. Neutrophilia of more than 7,500 it is the absolute neutrophil count. Neutrophilia of more than 7,500 per microliter is suggestive of a acute appendicitis. Also, urine examination may be done, which may show pus cells because so the pus cells, the presence of pus cells in the urine need not exclude the diagnosis of acute appendicitis, because sometimes because of the close proximity of the ureter and the bladder to the appendix, we may see some pus cells. CRB is raised in these children, and if these children are septic, then they have the plasma procalcitonin levels are high. So the most important thing here is that we have to go in by this basically the 3CU mechanism, that is the physical examination, ultrasonography, and the computed tomography. If ultrasonography and computed tomography they establish a diagnosis, then the operative intervention either by an open appendicectomy or a laparoscopic appendicectomy is indicated. While if it is negative, then we need to consider other differential diagnosis which may or may not require surgical intervention. This is this part of the thought process is very important, because invariably what happens is that even if ultrasonography and the computed tomography do not establish a diagnosis for acute appendicitis, then the differential diagnosis are not entertained. So this is the list of diagnoses that have to be entertained if the ultrasonography, if the CU of physical examination, ultrasonography, and computed tomography, they are inconclusive. Diagnoses that do not require surgery may be like the diagnoses that do not require surgery are Crohn's disease. Maybe the child is suffering with amoebic typhlitis, hepatitis, just a mesenteric adenitis, which can be picked up on ultrasonography. It can be just a dengue-associated serositis of the of the ileocecal region. It can be a typhoid. It can be a tuberculosis. Other important medical causes of abdominal pain have also to be looked into. These are henoch-Schönlein purpura, diabetic ketoacidosis, primary peritonitis, porphyria, lower lobe pneumonia, and also rarely in Burkitt's lymphoma and systemic lupus erythematosus. So these are the diagnoses. They do not require surgery for the management of abdominal pain. When the diagnosis, there are some diagnoses that may or may not require surgery. These are appendicular tumor or mucosal, typhoid perforation. A Meckel's diverticulum can easily mimic acute appendicitis. Ovarian torsion, especially in the adolescent female child, can very well mimic the acute appendicitis. It can be a psoas abscess, a diverticulitis. It can be just a ureteric calculus or a renal calculus, or it can be a torsion of an undescended testis, which is quite rare if the physical examination is made in a right way. Then the torsion of undescended testis has a less probability to get go unnoticed. Now the next, basically, so here in acute appendicitis, I have just not touched upon the feature touched upon this slide. According to me, most important in cases of acute appendicitis, in order to manage the where the ultrasonography and the computed tomography are not conclusive. Now, just a small word about appendicular mass. What is an appendicular mass? It is a phlegmon with central infected appendix with or without an abscess. It can be managed in two ways. One is upfront surgery, taking care to prevent trauma to adjacent small intestine, fallopian tube, ovary, and ureter. Or the patient can be conservatively managed with close clinical observation, serial ultrasounds, and intravenous antibiotics. After the child settles, he may or may not go for interval appendectomy, because many people are of the view that interval appendectomy is required, but it is a controversial subject because around 14 to 15% only have a chance of a recurrent appendicitis after a appendicular mass. Coming to intussusception. Intussusception is basically presents us to us with acute intermittent colicky pain, where the child draws his legs towards the abdomen and the chest. Also, there can be red currant daily stools, which are tried to show on this side of the slide. There can be a lump in abdomen. The lump is generally sausage shaped and with a concavity towards the umbilicus. Vomiting bilious vomiting is a late feature and should not be waited for. A non-bilious vomiting can happen in infants because of presence of reflex vomiting. Also, there is a sign of dance, which is empty right iliac fossa. Here, importantly, in this black, also we have to be important to see whether there is a blackish pigmentation of the oral cavity, which is suggestive of Peutz-Jeghers syndrome, or a typical purpuric patches of a henostolen purpura. These two conditions can lead to recurrent intersection. The ultrasonographic picture of interception, bowel in bowel kind of appearance on transverse view, and in longitudinal view we can see a intersusception going into the intersusceptum. What are the management? The interception can be managed in interception. The treatment options are basically have two limbs. If the presentation is within 24 hours without symptoms, or just without within 24 hours and after 24 hours. If the presentation is after 24 hours, we don't have many treatment options with us, but to have a operative intervention, which can be a open surgery or a laparoscopic surgery. Laparoscopic reduction. Non-operative reduction is attempted when the child presents to us within 24 hours of the start of the symptoms. It can be done with air, or it can be done with a normal saline, which is called as hydrostatic reduction. Air reduction needs to be monitored with fluoroscopy, while the hydrostatic reduction has to undergo can be monitored with USG guidance or a laparoscopic guidance. If a laparoscopic guidance is used, we'll have to do it in the operation room, while a USG guidance can be done at the in the radiologist room. I generally here prefer to do a air reduction, because air reduction generally allows us to a good. It does not basically, in a smaller child, it does not lead to the hypothermia, and also importantly is the air reduction also. If a small, there is a bowel perforation, that it can be detected very early in air perforation or in air reduction. Here, it is important to note that the ileoileal intersusception and jejunal intersusception usually are transient, but it is not. But they are not amenable to hydrostatic reduction, because the ileocecal wall does not allow the reduction to or the reducing agent, air or water, to get into to reduce the intersusception. While the ileopolic and the colopolic types of intersusception are amenable to reduction, or the air or water reduction. Coming to foreign body injection, this we generally see many people, many children with foreign body injection from 6 months to 3 years of age. They are generally foreign body injection do not require a great. Generally, they do well by conservative management. 10% require endoscopic removal, while 1% require surgery. This is a small diagram to show how to, or in one diagram, how to manage a foreign body injection. Most importantly, most important factor to look for is for the type of foreign body, number one. Then there are 3 pillars of the house, which are the esophageal foreign body, whether it is a esophageal foreign body, whether it is a stomach foreign body, or whether it is a small bowel foreign body. And the third important thing is a 24-hour watershed line. If it is the 24, if the child is asymptomatic and presents before 24 hours, then we can wait and watch. Wait and watch. If the child is symptomatic, that means he has either respiratory symptoms or has drooling of saliva or cannot swallow his secretions, then or the presentation is beyond 24 hours, endoscopic removal or a surgical intervention is indicated. But these two modalities of treatment are basically determined, or basically they are they have to be determined on the basis of type of foreign body and whether it is a esophageal foreign body, stomach foreign body, or a small bowel foreign body. These are the various types of foreign bodies, and is the Pandora's box that we can see in for a foreign body in a child. So this can be they can be coins. Coins are the most innocuous foreign bodies and the most common foreign bodies. If it is more than 25 mm diameter, that is more 2 rupee coin is a 25 mm diameter coin. Are difficult to pass through difficult to pass. Other important, and the next foreign body is the button batteries, which are very commonly nowadays used in the toys. They have to be they need to be removed within 2 hours, whether they are asymptomatic or symptomatic, because the hydroxide present in the button batteries leads to mucosal ulceration. Then if you have magnets, single magnets are generally considered to be innocuous, but if the magnets are double, they can stick to each other and they can make the bowel or the mucosa to come in between the two sticking magnets, and so can lead to mucosal injury or perforation or fistula formation. And so magnets, if they are double, if they are multiple, and along with metallic foreign body, they warrant a removal within 24 hours. Fish bones cause a problem because they are radiolucent, they cause trauma to oropharynx and can perforate the esophagus. So fish bones also require to be removed earlier. If it is nowadays toy motors can be seen as foreign bodies also in some children, and they require urgent removal because they are basically multi-component foreign bodies. Super absorbent polymers. These are the polymers which are generally used in the flower vases in order to give some moisture to the flowers, but they have a significant ability to increase in size and they retain moisture. And so, if a super absorbent polymer bead is swallowed by the child, it requires urgent removal. Foreign body which contains zinc and nickel and lead, they may cause allergy and toxicity and so require urgent removal. Aluminium foreign body cause a similar problem as that of fish bone because they are radiolucent. Along with it, sharp or long foreign bodies also warrant urgent removal. So this basic flowchart of management of foreign body ingestion needs to be seen in the light of these types of foreign body, and the history of the exact foreign body ingestion is very important. If a esophageal foreign body is seen on the first X-ray, then it generally is lodged at the ecopharynx. If it has passed the ecopharynx, then it only requires urgent removal in children with history of esophageal surgery, that is tracheoesophageal fistula or any other esophageal surgery, or the patients which have esophageal disease. Asymptomatic children or patients with innocuous foreign bodies can be considered conserved till 24 hours. If it is a stomach foreign body, it has a high probability of lodging at pylorus. If it is asymptomatic and if the foreign body is innocuous, they can be conserved, the child can be conserved for 24 hours. A small bowel foreign body generally lodges at the IC wall. If it is asymptomatic or the foreign body is innocuous, they can be conserved up to 7 days. Laxatives have a controversial role in the management of small bowel foreign body, and laxatives or high roughage diet generally does not give any any advantage in foreign body removal in the schools. Thank you very much. Thank you.
Thank you. Thank you, Dr. Dhananjay Vaze. I request all the attendees to put in their questions in the chat box or in the question answer sessions. And I request all the panelists to be with us till the end of this webinar. We'll be taking the question answers at the end of the webinar. So now we move on to our next lecture, which is by Dr. Meenakshi Bhosle on when to operate. The areas of interest are hernias, hydrocele, phimosis, and tongue tie. So, Dr. Vaze, can you stop sharing the screen, please?
Yeah, I stopped, I think. Is it still, you can see my screen?
Yes, yes.
Oh, sorry.
No. I stopped sharing the screen. Dr. Meenakshi.
Yeah.
Huh.
Then?
Yes.
Yes.
Dr. Meenakshi.
Yeah.
Yeah, warm welcome to you.
Thank you.
We switch over to your lecture now.
Thank you for the cordial invitation and the nice introduction. Good morning, friends. Today, I'm supposed to cover the most important topics which we deal in our day-to-day lives as pediatricians or pediatric surgeons, which are close to our hearts, that too in 25 minutes. Well, it's a difficult task, but I would try and do justice to the topic given. I'm supposed to cover, or rather highlight, the timing about when to operate these entities, but I think we need to brush up few details before we go on to the timing of surgery. Coming on to the hernias, we all know hernias are protrusion of intestine which give rise to a bulge. And now, since we are talking about inguinal hernias, I'll concentrate on the inguinal region. We see inguinal hernias more commonly on the right side. 10% of the cases are bilateral. Before we really understand when we should operate on a hernia, on inguinal hernia, we must understand the embryology behind this. We all know that the gonads form from the nephrogenic ridges in the retroperitoneum as early as 3rd month of intrauterine life. The developing testes are attached to the scrotum in a male child by the gubernaculum. And it is this gubernaculum which drags the testes into the scrotum. Rather, there is an important role of the processus vaginalis, which is a diverticulum or a peritoneal offshoot which precedes and guides the descent of the testes, which start about 6th to 7th month of intrauterine life. This diagram amply summarizes the descent of the testes. The testes reach the deep inguinal ring by about 6 to 7 months. They lie within the canal during the 8th month of intrauterine life and descend into the root of scrotum by about 9 months. After the descent of the testes, the processus vaginalis, which led to their descent, is supposed to close down. It is supposed to close down from above below under influence of calcitonin gene releasing factor. But for some reason, if this process does not happen, it is a potential hernia. If this neck of the processus vaginalis is wide enough, it allows the bowel to enter the inguinal canal and it forms a hernia. If it is too big, it may descend right into the scrotum, giving rise to complete hernia. The diagnosis of hernias is clinical. We may often be able to feel the thickened peritoneum, which is seen as a silk claw sign. Most of the hernias, it is a dictum. It is said that they should be operated immediately upon diagnosis. If we are not clear about the diagnosis, we may plan a second visit after about 2 to 3 months. 2 to 3 weeks. We may tell the parents meanwhile to keep a watch on the inguinal bulge, especially when the child is straining. And we believe the history and operate the hernia as early as possible upon diagnosis if the child is otherwise stable, fit for anesthesia. In many centers, it is a dictum to operate neonatal hernias before discharge from the NICU because there is a high risk of incarceration in these cases. But mind you, we need to take into consideration our backup, anesthesia backup, the NICU backup, the risk of apnea, risk of complications of anesthesia which may need, and therefore it is very crucial and we have to take the decision depending upon the individual case. Also, other associated factors why the baby was in an NICU in itself in the first place are important. So we have to have the risk-benefit assessment. And in any case, usually we prefer not to operate on neonatal hernias till at least they complete 41 weeks of post-conceptional age. Thereafter, the risk of anesthesia, the complications of anesthesia comes down significantly and it is safer to operate on neonatal hernias that point of time. We have to keep a triage. We cannot afford to operate early just because there is risk of incarceration and put the baby on a ventilatory support for another 2 to 3 weeks. It is rather easier and most cost effective to keep the child under observation, inform the parents, teach them how to diagnose, how to detect early incarceration and report us back, and keep the child on weekly follow-up. Herniotomy is a simple surgery. We do high ligation of the sac. Basically, all these contents are reduced within the abdomen and the sac is ligated. If the deep ring is too wide, we need to narrow that, otherwise recurrence of a hernia may happen. Well, there are two options available, open and laparoscopic. I won't go into the controversies. It depends upon the backup which you have in a particular institution and how the surgeon, the surgical team, anesthetists are used to it. Both are equally effective. Coming on to congenital hydrocele, we saw what our processus vaginalis, patent processus vaginalis is. If the neck of the sac is wide enough, like this, the bowel may enter, but in case it is narrow, the bowel cannot enter inside the patent processus vaginalis, and it is then only the peritoneal fluid trickles down and it gives rise to congenital hydrocele. We need to differentiate in each and every case whether it is a hernia or a hydrocele, because timings of surgery would differ, though the surgery essentially in principle is the same. Surgery for hydrocele in children is same as that for inguinal hernia, that is herniotomy, high ligation of the sac. Here, additionally, we need to drain in the fluid from the distal sac, otherwise the swelling may persist. Special mention to this particular entity, which is an encysted hydrocele. Here, the processus has closed above, below, and there is a lump shown in this slide. Here, we may require to operate the child early. Otherwise, we can keep the children with congenital hydrocele on regular follow-ups, see them every 2 to 3 monthly. And if the swelling does not regress by 1 to 1.5 years, we can operate. The exceptions being encysted hydrocele, or the swelling is increasing significantly in size, the child is in tremendous pain. There have been incidences of inflammation of the swelling. We might require to operate early, but once the infection has subsided. It is crucial to have each and every child with hernia and hydrocele to be seen by a pediatric surgeon before deciding on the timing, before giving them any guidance, because it is crucial to differentiate between hernia and hydrocele. Coming on to another common topic, phimosis. It is the inability of the prepuce to retract because of the narrowing of the prepucial opening. Phimosis may be physiological or pathological. Coming on to the embryology, as early as the 3rd month, a fold of skin forms at the base of the glans. The dorsal part grows more. There is keratinization of the glans and the inner prepucial surface. There is a common epithelial layer here. Lacunae or spaces form within these 2 layers, and then there is gradual separation of the glans from the prepucial skin, which happens over a period of time. If we see some statistics, in 6-month-old babies, only 10% of them, the prepuce would be retractable. By 2 years, in 50% of the cases, we can retract the prepuce. And the number comes on to 90% of the cases if we allow to go by 5 years. So when do we do circumcision? Circumcision, that is removal of the skin, though it is a very commonly done operation across world, I would not easily advocate doing circumcision without proper indication. It is done as a ritual in few communities, and we do it for treatment of the disease. Recurrent episodes of balanoposthitis, balanitis erotica, these are clear-cut indications. We need to do the circumcision early. Recurrent urinary tract infection is a relative indication. If once we have ruled out other causes of UTI like the vesico-ureteric reflux, PU valve, PUJ obstruction, and we cannot find any other indication, one might be justified in doing circumcision. This is a balanoposthitis, reddish looking penile skin, balanitis xerotica. This is how a circumcision is being done. Before doing circumcision, we need to confirm certain things, that the child does not have hypospadias, does not have a small phallus. We might require the skin in reconstruction. There is no pinoscrotal transposition or fusion. And nowadays, ballooning of prepuce is not considered as an indication of circumcision. Circumcision is not risk-free. We can have bleeding and infection and a lot of psychological issues coming up after circumcision. In fact, it is coming up as an issue related to child rights, which strongly prevents, which strongly tells us that we should not be doing circumcisions unnecessarily, because the child may sue you later if you are not justified in doing why you are doing circumcision. It is considered as a violation of human rights of the male babies, and there has been a great movement in this regard. So I think we all have to be very cautious and put it down medico-legally why we are doing circumcision in a particular case. It might come up 20, 25 years later upon. Coming on to umbilical hernias. Again, we see the children very commonly in our OPDs. There is a hernia bulging through the umbilical ring, which is wide open. We do not repair umbilical hernias till the age of 3 years usually, unless there are multiple 2 to 3 episodes of irreducibility. Hernia, something like this, can be dwelled. The child can be kept on follow-up and dwelled at the age of 3 years, beyond age of 3 years, whereas supraumbilical hernias like this, where the umbilicus is normal, but there is defect above the umbilicus, need to be operated early, even before 3 years. Coming on to most common, most evolving and most controversial topic, that is tongue tie. It is inability to protrude the tip of the tongue beyond the lower lips or beyond the oral cavity, and it is restricting some important functions of the tongue. Incidence of tongue tie is seen to be noted to be 4 to 11% in newborns alone. Previously, we used to think and operate when the child had drooling of saliva or slurred speech, there is defect or deficient development of the facial muscles, or the child is brought as a toddler or even older to us. But nowadays, much more attention has been drawn towards tongue tie in neonates, leading to feeding difficulties because of improper latching and sucking. And I think it is coming up in a big way. Tongue tie can be obvious like this or this, and not so obvious like these cases, which usually do present later to us. There is restriction of the tip of tongue. It cannot be lifted to touch the hard palate. This is causing cupping or humping of the tongue. Different grades of tongue tie. Only the tip is adherent, little posterior part, little posterior than that, and in this diagram, the complete tongue is tied, which is most severe variety. I have not seen such a case in 15 years, yet to see, maybe quite rare, but these grades are quite common. There is a lot of awareness about tongue tie, giving rise to feeding problems, especially after Lactational consultants are coming into picture to solve the feeding issues. Here, a word of caution, though it is important, and most of the neonates, we saw almost incidence of 11% in reported series. We see quite a few neonates admitted in NICU and coming to our OPDs with other ailments having tongue tie. The crucial point is, does this child need surgery? Sooner, later, when to operate? Does he require surgery at all? Well, while preparing this PPT, I went to various detailed topics, detailed reviews or reports on tongue tie, and found out this, the different classifications. If there is a tongue tie and still movement of the tongue is normal, movement of the tongue is allowed, you don't need to do anything. Something like this, a mild tongue tie, the free tongue is about more than 15 to 16 millimeter. If there is some restriction of degree of the tongue, there is range of motion of the tongue is restricted, we need to do something. If it is moderate, the restriction is up to 8 to 11 millimeter. In severe, no tongue is free so that it can do its normal function. And here, almost the tip of the tongue is attached. It definitely needs early surgical intervention. This topic has been dealt with in great details in WASTE. And this is court law classification I just spoke on to. And this topic has been taken up to a great extent. I just saw one of the webinars organized by lactational consultants on this topic. So we need to be more knowledgeable on this. But a word of caution here too. Mind you, friends, no surgery is risk-free. So when we are considering doing tongue tie release, we need to assure that we are maintaining asepsis. The instruments are sterile. If we are using lasers, the child is adequately sedated. We are not damaging other areas that we need to be careful about, because tongue tie release, though it may be a very short procedure, considered in some hospitals as a day care procedure, office procedure rather, they just snip the frenulum by using a scissor. But when you are not using proper sedation, not utilizing proper analgesia, anesthesia, I think the risk of complications is much higher. So we have to be little cautious on this aspect also. Severe grades of tongue tie, yes, we need to do neonatal release also, tongue tie release also. The surgery is named or recognized by using different words, that is frenulotomy, frenulectomy, tongue tie release. Whatever is the nomenclature, the procedure is simple. This tie is released either using electrocautery, scissors, and we usually prefer to take sutures at the mucosa of the buccal oral cavity, the buccal mucosa, to prevent infection and bleeding and the complications arising thereof. I think this is my last slide. Thank you all for the patient listening. I would be glad to answer any questions during the question answer session.
Thank you, Dr. Meenakshi. That was an excellent lecture, giving us excellent insight and information on the most common problems that we come across in our OPD practice: hernia, hydrocele, tongue tie, and phimosis. And I would request, I would request you to be with us. We'll take question answers at the end of the webinar, please.
Sure.
Thank you so much. We are well within times. We will move on to our next lecture by Dr. Dasmeet Singh, which is on pediatric surgery. When do we refer? And the areas that cases that he will be covering is rectal prolapse, lithiasis, and acute scrotum. So over to Dr. Dasmeet Singh, please.
Thank you, Manisha. So let me just start by sharing my screen.
Yes, sir. It's visible now.
Yeah. Right. So each of these is a big topic in itself, but I'll try and do justice, at least a few of those important algorithms I should be able to impart today. So let's start with the testicular torsion. So the typical history that one sees is that the patient comes to you with either an abdominal, inguinal, or a scrotal pain. And being ischemic pain, it will always be a lot more severe, and the symptoms will far outdo than the signs are suggesting. All intra-abdominal organs can undergo ischemia, but today we're going to be only discussing the testes. So the minute the patient comes to you, there are certain protocols which have to be followed before the patient actually gets referred to a pediatric surgeon. There are certain steps which have to be done, and which what we call as the casualty level steps. So the questions that I'm going to answer is ultrasound and Doppler always compulsory? Is orthopexy done at the same time or later? Can an infarcted testes be preserved? And 25% of the time there's actually only a torsion of the appendage of the testes, which may not need active treatment always. So the typical picture, this is a neonate which came with history which suggested that the patient had hernia, and then the patient was referred for an obstructed hernia. But if you look carefully, the scrotum, as you can see, the scrotum is seen to be pretty small on the left side. So it was more likely to be, kind of a torsion of an undescended testis. And the ultrasound done proved that, which showed the swollen testes. And when I opened the patient, you could see that it was a classic infarction of the testes. There's no way such a testes can ever be preserved. And this is a typical variety of an extravaginal torsion. That means the entire cord structures along with the tunica vaginalis, they all rotate. And because of that, you get infarction or ischemia of the testes. So most important is the time of presentation after the onset of pain. So if you have a patient who's come to you, more than 24 hours after the pain started, and there's a lot of scrotal erythema, edema, so then there's no urgency in doing the surgery. If the patient has come to you and it's like close to 6 hours or less, then you don't waste time on anything and explore urgently. If the patient has approached, let's say about 12 hours, up till 12 hours, sometimes the salvage of the testes is possible. More than 12 hours, generally, you cannot salvage that testes. And if the entire scrotum is not tender, entire testis is not tender, only one tiny nodule is there, that suggests an appendage of the testes, and surgery again may not be done at all. Yet another patient, you can see inguinal scrotal redness and severe pain. The pain is continuous. When you open up, you'll see that the patient does not have any blackening which is seen very obviously, but the tunica vaginalis is quite edematous. But once you open the tunica vaginalis, you can see the infarcted testicular tissue lying within that. So that needs to be excised. Of course, the testicular torsion, another subtle case, but because the ultrasound and the Doppler suggested that there's torsion, on opening the tunica vaginalis, you can see that the black portion of the testes is seen, which is infarcted and has to be removed. So the two most important things when we have to make a decision on whether that is torsion testes or epididymoarthritis or anything else, it depends on something called as a twist score and also the Tanner staging. I'll show you how this is used. Now this is at the level of the casualty that we make them aware of when should they rush a pediatric surgeon there, or when do they have time to get the reference done. TWIST score is an acronym for testicular workup for ischemia and suspected torsion score. Okay, so the history and physical examination, the testicular swelling itself is given 2 points, and if the testis feels hard and tender, it's given 2 points. If there's an absent cremasteric reflex, nausea, vomiting, or the testes is lying higher up than normal, that is given 1 point. Then you add those points and you come to a score. And as far as the Tanner staging is concerned, we generally try to keep a picture chart, as you can see, and that helps the whoever is the observer to decide whether it's 1, 2, 3, 4, or 5. And with these two informations, then we go on to the actual protocol. This has been a protocol which has been evaluated and tested on multiple occasions and proven to be absolutely reliable. So the pediatric patient who comes to you with an acute scrotum, you calculate the twist score first. If the twist score is 0, then there is no testicular torsion. You can just send them home, but tell them that there is absolutely absolute necessary, in case it's an intermittent torsion, that the next time they get the pain, patient has to be referred back immediately. And if the patient has a twist score of 1 to 5, then you get an ultrasound done to evaluate for testicular torsion. When we say ultrasound, we mean Doppler, because ultrasound per se alone is not enough. If the twist score is 6 or 7, that is a high risk category. In that, you have to then plan with the Tanner score. And the Tanner score, if it's just 1 or 2, then you can do an ultrasound to determine whether it is actually torsion or not. And if the Tanner's is 3 or 3, 4, or 5, then that is an hyperacute situation where one has to just immediately rush to the operation theater and operate the patient without any investigations having been done. So the predictive positive and the negative predictive value is extremely high of the twist score. And when coupled with Doppler or Doppler alone, which is the gold standard, you get a very, very good sensitivity. But if you have a high clinical suspicion and things are approaching 6 hours, you just explore the patient. Since the abnormality is higher on the opposite side, the same bell clapper deformity as it's called, the incidence being 40%, then we should always try and do the orthopexy and save the other testes, because that will be the only solitary functioning testes. Now, testicular appendage torsion, sometimes you get that, and it's most of the time it's appendix of the testes, and sometimes other parts of the remnants is also possible. And if most of the time it goes unnoticed, patient gets severe pain, thinking to be baronopostitis, the patient is treated, and over a period of time, patient develops a blue dot sign on the upper part of the hemiscrotum, and that gives you confirmation that it was appendicular torsion of the testes. There are ways of determining the difference. I think the most common thing is the minute you get scrotal pain, normally in our circumstances, almost everybody does get an ultrasound done, and on that it can be made out. But again, not always, not in advanced cases. In advanced cases of testicular appendage torsion also, the clinical features will look exactly like testicular torsion. Now, this is a case I had to do recently because a patient came with gross edema, swelling, and that actually turned out to be the torsion of the appendix of the testes. And just that much part have to be removed. You can see the surrounding epididymis, etc., are pretty edematous, but the testis is absolutely normal. So this patient will have a normal testicular function. Now, testicular torsion, when we open up, first thing we do is try and untwist and see whether the circulation is coming back. Like in this particular patient, you can see that the circulation has come back within a few minutes, absolutely normal looking testes. and then classic orchopexy is done of this side as well as the opposite side. Uh, you see this particular patient, again untwisted, and from a black looking testes, slowly the color is coming back. First the vessels start becoming red, then the testes per se, the tunica albuginea and the vessels which can be seen within that. Initially they are black, looking as though they are thrombotic vessels. But once the testis changes its color, then the next thing to do is you take a small incision over one of those vessels. Initial blood might be slightly on the darker side, but what you're looking for is that the bleeding should slowly become absolutely red and freely flowing. So there. So that tells you that the testis is absolutely viable and they can go ahead and pex the testes. With that, we'll go on to the next presentation. Is the management of rectal prolapse in children. Now, this is a very, very important condition because it's seen very, very commonly in everybody's OPD. And usually the child is between 1 to 3 years of age. And the adult way of classifying like partial mucosal prolapse and full thickness prolapse generally doesn't apply to children, as has been seen in all recent literature. Most of the time it's full thickness prolapse itself. So from the clinical standpoint, rather than grading the prolapse, I think it's only important to really wonder or rather classify them into two types of prolapses. One is a rectal prolapse, which is acute in nature. That can be the first episode when the patient presents to you, or it could be a recurrent episode also. And the second would be a chronic rectal prolapse, which would have some kind of a pre-existing or predisposing factor which will cause the prolapse. Now, the acute rectal prolapse is undoubtedly the commonest variety in children, and usually following some kind of an acute malnutrition like gastroenteritis or a debilitating disease. And when the patient comes to you, ask the patient to strain, you just can't see anything. And so you don't know whether the prolapse is actually there or not. And under the circumstances, just believe the mother. They have seen it, they know it. And if you have a very sharp mother, generally they've taken some kind of a photograph, and that makes it much easier for us to diagnose it. And you do a per rectal examination, digital rectal exam, and most of the time they have a good anal tone. So the treatment is relatively easy. So you start the patient on good diet, high protein included. Then laxatives and stool softeners are given, and a buttock strapping is given. So that kind of an acute rectal prolapse, and that's the way a buttock strapping is given. You can see that you squeeze the two buttocks together and strap it with the help of dynaplast. Leave the anal part open so that this part should not be disturbed at all. And if you leave it like that for 15 days, 90% of the patients, the prolapse would have disappeared. You can leave them longer. You can teach the relatives also how to apply that dynaplast. And most of the time it is successful. Those children who do not respond, then you need to produce some kind of a fibrosis within the submucosal layer so that the mucosa and the muscles, they stick together and the prolapse stops. So this is generally done either with the help of chemical sclerotherapy. We use 5% phenol in almond oil, and a 4-quadrant submucosal injection is given, or we can use electrocautery also, or laser also for doing the same thing. But generally these are again quite rarely required. The ones who do not respond to even this, then a third stitch can be resorted to. A third stitch is basically an encerclage around the anus. Should not be too tight, should not be too loose. So the best way is to use a 10 size Hegar's dilator and you tighten the stitch over it. I always prefer to use soluble stitch, which will dissolve over a period of 4 months or so. And by then again, the prolapse would have disappeared. Many of them, it doesn't happen. And in those cases, then some kind of a surgical technique will be used. Not many people are fond of the tear stitch because especially if you use non-absorbable, it can cut through the mucosa and cause a lot of problems and fibrosis. In chronic rectal prolapse, there are certain predisposing causes. Now, surprisingly, chronic constipation, out of all the patients who have chronic constipation, only 3% of them actually go on to develop a rectal prolapse. Reason is not very clear, but that's what is the observation. Cystic fibrosis, almost 20% of them will develop a rectal prolapse. Then any kind of a neuropathic involvement where the pelvic floor is quite unsupported or weak, same as happens in extrophy bladder, and with the patient then straining at urine or stools, like in a stricture or something, stricture of urethra, or iatrogenic. Now this is after a pull through which has been done for anorectal malformation or Hirschsprung disease. If the technically if something is not very correctly positioned, etc., then one can get a rectal prolapse. Of course, there are those cases where there is a neuropathic origin, like supposing if the nerves themselves S234 are deficient. In those cases, then again the prolapse can happen. Whenever you get a recurrent prolapse, one has to look for the anal tone, as you can see over here. And the first thing that comes to mind is, was this patient sexually abused? So that has to be dealt with very, very carefully. We use psychologists whenever we discover anything like this. And the psychologists who are far more adept at getting the history out of the patient, because when we spend a very short period of time with the patient, they may not actually come out with the history of what is happening. But the psychologist who spends an hour with the patient can many times elicit this history, and it's extremely important to nail it right in the beginning. But the anal tone can be low, like you do a the digital rectal examination, and the anal tone can appear low. It can be because of a chronic prolapse, or it could be caused by the prolapse itself. So one needs to be careful in determining the cause. If the patient's prolapse becomes chronic, it leads to a lot of ulceration, as you can see over here. And there's a technique of reduction, which has to be taught to the relatives. So initial part will always be conservative, always give a long gap of a trial with conservative line of management. And only if it doesn't respond to almost 1.5 to 2 years of trial, then surgery is thought of. In a neurogenic bladder, there you can see that the entire anus itself is so lax that the rectum protrudes through without any problem. When it comes to surgical procedures, after 12 to 18 months minimum of conservative trial, then we can do procedures. The two most commonly done procedures. One has to remember that procedures are not completely free of complication. So to take the decision to operate on something as innocuous as rectal prolapse, one has to have very good reason. Okay, so a long drawn failure of conservative trial is when one starts thinking of doing something surgical. So the commonest are done a laparoscopic suturing technique, where one places a mesh which is sutured to the sacrum, and the mesh is then wrapped partially around the rectum. Or the Pearl's procedure, where posterior sagittal anorectopexy is done. Since all pediatric surgeons are quite familiar with this technique was popularized by none other than our Pune pediatric surgeon, Dr. Bobby Fatke. And it's a very well recognized and a highly successful technique of managing. The third most common technique in such a scenario, when you see a chronic prolapse like this, then that's an Altoma's procedure where you have to excise that entire prolapse segment and then resuture it. So this particular thing is called as procedentia. where it's impossible to reduce the prolapse. Just to show a short video, see how lax the anus is. Okay, we open by the posterior sagittal root, split open the coccyx, and then you take the muscle. The sphincter muscle is very robust in these cases, unlike in an anorectal malformation. Whenever we do for a rectal prolapse, the sphincter muscles are very, very large. And then those sphincters are tethered to there's a sphincter on one side, that's the rectal wall on the other side, and you take the sphincter on the other side and you fix the rectum to this sphincter muscle. And the minute this is done, you see the prolapse disappears. The cosmetic result is excellent because you get a nicely tucked in anus, and that's the final result. There you can see the result is seen even on table, how nicely it heals. There's hardly any scar which is visible. Now I'll go to the third part of my presentation, which is pediatric calculi. Now here I'm not going to go too much into the detail because I'm sure all the pediatricians are pretty aware of all the theoretical part of calculi. But I'll just touch upon that. Basically 5% of the general population has calculi. They used to be less common in pediatric, but now the incidence has gone on increasing. Secondly, earlier we used to see a lot more bladder stones in children, but now bladder stones have reduced, and now we are seeing a lot more renal stones. And what is important to understand is that once a stone, always a stone. That dictum is very, very important, because once a patient gets a stone, lifelong the patient is going to keep developing stones. That metabolic problem is there. And within 5 years, almost 50% of them would have got the recurrence of the stone. The commonest metabolic risk factor that we see is hypocitrullia and hypomagnesuria, rather than hyperoxaluria and hypercalciuria. Dietary excess, vegetarians are more akin to get uric acid stones because their urinary pH is lower, and non-vegetarians are more likely to get calcium stones because their urinary pH is higher. So dietary excess of anything is bad. And when it comes to stone forming in some kind of an anatomic abnormality, PU junction obstruction or a vascular junction obstruction or a PU valves, only 9% of the time we are able to identify some kind of an abnormality. Now the principles of management: if a stone is less than 5 millimeters, almost always is going to get passed out, and you might just need to give some alpha blockers, tamsulosin or something to help to relax the ureter and dilate it so it passes out more easily. Remember, it cannot eliminate the peristalsis, it just reduces the force of peristalsis and dilates the ureter. Then if the stone size is between 5 to 10 mm, it may pass out. Even up to 10 mm stone can pass out without pain also in a child. Now more than 10 mm will definitely need surgery. If there is some kind of an anatomical defect, then that gets precedence over the stone surgery, or sometimes both are done together. Preventive measures, according to whatever the stone composition or the metabolic defect that is discovered, that is generally followed up by the pediatric nephrologist, and they do a very good job of that, and to prevent newer stone formation. But I think what our level, what we have to stress on the patient is that water is to be used as a drug, and that's the best way to prevent stones. Not that it will actually prevent the formation of stones, but when the flow of the water is kept under higher pressure, more diuresis keeps happening. When the stone is still in a crystallized form, in a crystal form, or when the stone is small, it should get passed out. So the minute the stone becomes big, that's the time when it will need some kind of a surgery. And the second thing that we have to stress upon any patient who is discovered with stone is that a regular follow-up ultrasound has to be done. Okay, initially maybe 6 monthly, and then subsequently at least once a year ultrasound has to be done. Generally, we tell them to tie it up with their birthday or something, 1 or 2 days earlier or later. So at least serves as a reminder that they're supposed to get an ultrasound done. There is absolutely no place for open surgery in pediatric patients for stone. Okay, and that's very important to understand, because the patient is going to need surgeries again and again, maybe lifelong. And so the least amount that you can do to get rid of a stone, the better it is for the patient in the long run. What are the types of procedures that we have done? Everything is possible. Whatever is possible in the adult is possible in children. And only if you have, like, let's say a PU junction obstruction, which needs a pyeloplasty along with a pelvic stone, then obviously open surgery will be required. But in the absence of those conditions, it's important to remember that most of the time we have to hedge on the endoscopic procedures. And initially, when we had started off doing stones in 2002, we had a certain criteria which has gone on changing over a period of time. So today, a child with a small stone burden in the kidney, we can resort to an ESWL, provided the child is more than 5 years of age, and almost 95% of the kidney stones can be tackled by just one sitting of ESWL. But scarring of the kidney can be an issue, so one has to be very, very careful in doing it. So it better be a localized stone, and you should have a very good quality ESWL machine which can focus the energy directly onto the stone. This is a child who presented with a left renal pelvic stone, 7 years, male child, severe left flank pain with vomiting, and it was a 12 millimeter renal pelvic stone. Everything else was normal. So it was easy diagnosis that we could easily do a PCNL. And this is how a PCNL is done. So you place the patient in the prone position and puncture the kidney. Now there's already a ureteric catheter which has been placed from below, which helps us to identify the pelvic elevation system. And then a guide wire is put from below, as well as now once the kidney puncture has been made, a guide wire is put from above. Then we dilate this track and we use C-arm for guiding. That's a steel rod which is put inside, so that the more the dilators that you need to put, it should not tear the kidney, it should not go in any other path. And then the amplage sheath is put inside. Amplage sheath is kind of the cannula with which we will be able to through which we can put in our scope. And with that, we have gained the access. And once we are inside and we can view the stone, then there are multiple ways to tackle it, either by holmium laser or using lithoclast, and various ways of doing that. So I'll show you a few. So this is a massive bladder stone which you can see, and this is how it was tackled. So first you have to rule out why the patient got such a big bladder stone. So this is a cystoscopy part which is being done, and that's the verumontanum. There are no PU valves, as you can see. We get into the bladder, and that's the massive stone over there. And holmium laser, it just evaporates the stone. There are different modes available with the holmium laser. So this is either the dusting mode or the blasting mode. So during the dusting, you can just make a fine powder out of the stone. And as you can see, once you direct the fiber towards the stone, there's a foot pedal. You just press on the foot pedal. You make the adjustments according to how much ever energy you want to give to the stone. This being a larger stone, we used a lot more energy. And then you break the stone into smaller bits, and parts of it get vaporized. And in a patient where such a large stone is there, we do not want to keep the urethra cannulated for too long with our cystoscope. So I did a PCCL, that is percutaneous cystolithotomy. The way you do PCNL into the kidney, a PCCL is done into the bladder. And with the help of that, all the stone fragments were cleared out and the Foley's catheter kept in position and you come out. So, so that's a very, very good way of tackling the stone. Another very big advancement that happened is retrograde intrarenal surgery using a flexiscope. And so going via the urethral orifice itself, you can go via the ureter, reach the kidney. And of course, we have used RIRS in children. The least age we have used is about 4 years. I would not recommend below that because it might land up tearing the vesicurectory junction. Sometimes you have to do it staged. Like there's one patient where I have staged it, I've just put in a DJ stent, and now patients are waiting for the definitive RIRS. This is what is done once we reach the kidney. There you can see the various callices are seen. And then again, the holmium laser is less than a millimeter in diameter also. So you get different sizes. This is, I think, 365 nanometer laser fiber. You can see the stone. You can just powder the stone by using the dusting mode, and that doesn't leave many fragments also. And if there's a lot of inflammation, you can leave a DJ stent in position and come out. And over a period of time, whatever little bit of small fragments are there, they get passed out. A DJ stent will drain initially for the first 24 hours through the stent, but after that it drains peristent. So even the larger fragments can get passed out. So that's the guide wire put inside to help the DJ stent to be directed into the kidney. And once the clearance is done, that's the end of the procedure. So there is no incision, nothing. So using the usual ureteroscopes, when it comes to URS, I have purposely omitted URS because of the time factor. But now we have ureteroscopes which are as less as just 4 French in size. So the danger of ureteric avulsion, which was there in bigger children, rather bigger scopes earlier, that is also not seen nowadays. In the times when supposing you don't have high-end instrumentation, but you have an obstructed view junction calculus. So this is a routine procedure which I used to do earlier. So you go into the retroperitoneum without even opening the peritoneum, identify the ureter, open the ureter. Okay, this is a technique I developed to get the stone out. So you hook it by one instrument, and then the stone is removed along with one of the ports, and that's the end of the procedure. You don't even need to take a suture on the ureter because it doesn't leak. Since it's in the retroperitoneum, the peritoneum just collapses over it, and that's the end of the ureteric stone. Later on, of course, the stone analysis can be done, but stone analysis hasn't really helped many patients because almost every stone will show you all the elements present. So it is more important to do a 24-hour urine analysis and blood workup to find out the calcium, phosphate, and other ammonium levels, and come to a conclusion on how exactly to prevent the stones. But most important prevention is, one is water, and the other is strict follow-up. So endoscopic management of stones is safe, easy, and is a very good viable option in this era of minimal invasive surgery. And that has left virtually no place for open surgery for only stones. Thank you. Thank you for a patient hearing.
Thank you so much, sir. This was an excellent presentation, excellent talk on not so common, but nevertheless very, very important clinical situations in our pediatric practice. We will take on the question answers now. There are a few questions which have been answered in the question answer box directly by our faculty members. So I request all the attendees to just go through the questions and answers in that section. And there is one question to you, sir. Diagnosis and management of posterior urethral valves.
Okay, that's a separate topic in itself, where
Yeah.
the usual presentation would be commonest would be UTI, and nowadays it is more like antenatally diagnosed. And the primary treatment, because again we have very fine scopes, is to directly go inside and fulgurate those valves. More important than that, treat the infection, see whether the kidney function is good, evaluate the whole thing, do a primary fulguration. Very rarely we need to, do a kind of a diversion, and we have moved away from diversions out of the bladder. Most of the time, the diversions, if at all needed, will be in the at the ureteric level. But then the treatment of PU valves is not something you do the fulguration and you forget about it. You have to virtually follow up these patients lifelong. And at least till the age of 18, they have to be following up with a pediatric surgeon. And the reason is because there can be kidney dysplasia, there can be other associated problems, a neurogenic bladder, and almost 11% of these PU valves will have a neurogenic element called as a valve bladder. So that should not lead to knocking off the kidney by causing secondary dysplasia because of a high pressure bladder. So a very careful follow-up is as important as the primary treatment that is given for the valves.
So how often do you call them for follow-up?
I think every patient will have a different follow-up regime depending on what the problem is. So right now it's very difficult to make all those case scenarios, because the timing is very short. But if you take a ballpark figure, I would say, like, let's say if the patient has been fulgurated at birth, the first follow-up will be after 7 days, after the catheter has been removed and patient discharged. So 7 day you'll do a urine examination. After that will be monthly for the first 1 year. A urine routine is done and patient is kept on chemoprophylaxis. And after that, after 1 year, then the entire investigations are done again. That's my practice. We can do the investigations earlier, but because if there's a reflux, etc., then it will lead to a lot of confusion on what is to be managed, and sometimes you over manage the patient. If the patient is not getting urinary infections on follow-up, I would be pretty happy that the stream is good and the patient is not getting UTI. Tells you a lot about the the health of the urinary system as a whole. So I would be very conservative in that respect, and do investigation only after 1 year, where an MCU, DMSA scan, etc., depending whether there's reflux or not, are done. I am not a proponent of routine circumcisions. I never do a routine circumcision unless the patient keeps getting pus cells on in the urine without demonstrable obstruction, then, or a reflux. So if your urine is kept clean by the chemoprophylaxis, there is no need to do a circumcision. But yes, if the patient keeps getting UTIs, circumcision is also one of the things which need to be added.
Another one query is, what is your opinion regarding dietary recommendations, if at all, to avoid renal calculi?
Okay, so dietary restrictions again will vary according to the vegetarian or the non-vegetarian type of personalities. Okay, so by far and large, if one can get some idea about what the metabolic abnormality is, but then that is seen only in about 30 to 40% of patients. In the vast majority of the patients, you will not know which kind of stone it is. What you do know is, okay, if it is seen on a plain X-ray or a CT scan. CT scan is 99% suggestive. If a stone is seen on the CT scan, then you know, okay, there's adequate amount of calcium in it,
right,
because it's the calcium which causes the density or the radio opacity. So
Rodeo.
then, so calcium, then the commonest part is calcium oxalate and calcium phosphate. So avoiding, when it comes to oxalates, then we are looking at avoiding beetroots, spinach, chocolates, nuts, all those, that
Right.
category of foods which are high oxalate containing. If it is calcium that we are looking at, then avoiding calcium containing. So calcium substitute should be avoided. Okay, no calcium tablets or syrups in such patients. Then patients who are brought up mainly on milk, you reduce their milk content to reduce the amount of calcium. Then you of course you investigate for hyperparathyroidism and the other causes of hypercalcemia and hypercalciuria, and accordingly then the diet is tuned to them. If it's uric acid stones, then obviously non-vegetarian and fish etc have to be completely eliminated out of the diet.
There is one more question. I think it is to you only, sir. What is the role of chemical analysis of urine in calcular management or prevention of its recurrence?
Absolutely, very, very important question. See, the urinalysis tells you so much about what is happening with the kidneys. Okay, and I think a pediatric nephrologist will really answer that question much better than I can. But definitely the types of crystals that you get, the pH of the urine. We know that if the pH tends to become acidic, you will get more uric acid stones forming. If the pH tends to be alkaline, you will get more calcium stones forming. So everything that has to be moderated within the normal range of all the parameters. Urinary infection, we are so used to just tuned to just looking at the pus cells. Okay, pus cell less than 5, everything is fine. Pus cell more than 5, get a culture done. But that's not the case. You should look at everything else. The leukocyte esterase might be an indicator of infection also. Then the struvite stones, the triple phosphate stones, they develop in an acidic, in a kind of infected environment. So subclinical UTIs can also be there, which can cause stone formation. So urinalysis is extremely important.
Extremely. Okay. Thank you so much, sir. I would again insist all the attendees, there are a couple of important questions which have been answered by Dr. Meenakshi in the chat box. Kindly go through the questions and the answers given. And I think that brings us to the end of this webinar. Dr. Sanjay?
Yes.
Natu?
So again, just like the pediatric orthopedicians, the pediatric surgeons have been excellent with the
Absolutely.
time, and we are absolutely as per the timetable which we had put up on the groups. So we are finishing well in time and answered all the questions on the chat box or live. So we are very thankful to the pediatric surgeons, Dr. Rasmeet Singh, Dr. Meenakshi ma'am, Dr. Dhananjay Vaze, for helping us deal with these some common, some a little uncommon pediatric surgical problems. So that's it from me, Manisha. I think we can end the session after your vote of thanks.
Yeah, so a vote of thanks to our orthopedic and pediatric surgery consultant and faculty members today for an extremely crisp and informative session on, as Dr. Sanjay has said, some very common, some not so common, and yet very important OPD scenarios and problems. Sunday well spent, well within time. We have not overshooted at all this time. So I think all the attendees
can I say something on that, Manisha?
Sure.
Basically, see, everybody was a surgeon. They are all used to being given OT slots. So we have to know that, okay,
can't afford.
We can't afford it. By 1 o'clock, we have to hand over to the next surgeon. Yeah. So we do that.
That's a good point, sir. But we are happy that we have had an excellent academic session on a Sunday well within time. So I thank all the faculty members for giving us this hugely informative session today. I thank the DG Shield platform providers for giving an excellent technical support. Absolutely no obstructions throughout the webinar. And yes, but last but not the least, almost about 200, I think, attendees today. Is it Dr. Natu? I think we had around 200
right, about 200 participants.
Yeah, so a huge thanks to all the attendees also. So that brings us to the
Manisha
end
ma'am.
of this webinar. Yeah, sure.
Manish, thank
Yeah,
you
yeah, Dr.
for
Deepak.
your hosting. Thank you for your hosting. Very good presentation of all the
Yes,
faculties. Thank you,
that is very
Napu sir.
important.
Yeah.
And
Thank you, thank
thank
you.
you to IAP Pune for giving us the opportunity. Thank you so much.
Thank you, sir. It was our privilege to
pleasure.
listen to your presentation. And I think we are good to end this webinar.
Right.
So
Chirag from
signing
BGC.
off.
Chirag, we can
Yes,
end
sir.
the webinar.
Yes, sir. Thank you, sir. Thanks a lot.
And I request all
Thanks,
the
Chirag.
participants to join us for the next webinar, which we will conduct soon.
Oh, not for lunch, yeah?
No, not for lunch. That
We are
is
missing that.
online.
We are missing that in this
Yeah,
COVID
I'm missing